Good morning, everyone, and welcome to the ANTI-SUPERBUGS PCP final event. In this webinar, we will show the results of the ANTI-SUPERBUGS PCP project, which mobilized 6 public and private procurement organizations to jointly put in action a cross-border procurement procedure to tackle antimicrobial resistance. We are really happy to be here and show the results of a long and challenging project that started back in September 2016, so some time ago. Let me introduce myself. My name is Jon Arrizabalaga. I work as a project manager in the Agency for Health Quality and Assessment in Catalonia, and I am the coordinator of ANTI-SUPERBUGS PCP project. Together with all the project partners, as well as participating contractors who are having a dedicated space today, we will show the perspectives of the whole consortium regarding not just the achieved results, but also the employed methodology, including all our gathered lessons learned. So I will share the agenda to go through it briefly. This is divided in 3 big blocks. We will start with an opening session. We will have here the welcome and introduction of Elena Kukarenko, who is the European Project Officer of ANTI-SUPERBUGS PCP project. And then we will have Marie-Cécile Ploix, coordinator of European Joint Action on Antimicrobial Resistance and Healthcare Associated Infections, JAMRAE, who will put in context the relevance of addressing antimicrobial resistance in Europe. Then it will be myself who will present an overview of ANTI-SUPERBUGS PCP project from the very beginning, with the unmet needs identification till the end and the execution of the pre-commercial procurement and the prototype tests in clinical setting. Then we will move to the second floor, the second big pillar of the event, where the 2 final contractors will present the final solution. We will have Backwatcher Consortium, which is composed of Grupo Pulso, New Wave, Peperdrop, and Ion Gas. And afterwards, we have presented the solutions of Sense for Care, which consortium is composed by Tech for Care and Sense Solutions. After a break, we will move and we'll then gather the perspectives of the bias group. So we'll have representatives from the Institut Català d'Oncologia, from the Provincia Autónoma di Trento, from Helios, in Wuppertal, and Fundació Assistencial Mutua Terrassa. We will then have as well the opinion and the perspectives from the supporting entities in the project that had a key role also in the success of the project. And here we'll have Sara Bedin and Ulla Elofsson from the Research Institute of Sweden. Lastly, in this block, we'll have Maria Sanchis from Aquas, who will present the project Radar PPI, which is the project that comes beyond ANTI-SUPERBUGS PCP and from where we will leverage the results obtained in this project. As a third and last block, we will have a roundtable where we will highlight the relevance of the evaluation as a mechanism to increase the ability of innovation procurement to transform health delivery. Here, this will be moderated by Rosanna Alessandrello, Value-Based Procurement Director in Aquas, and we will gather here different perspectives. We'll have Carmen Laplaza Santos, Deputy Head of Unit in the Innovative and Personalized Medicine from the European Commission, as well as Liv Boss perspective, Policy Officer in the Pre-Commercial Procurement and Public Procurement of Innovation in the European Commission. From the procurement organization perspective, we'll have Mark van den Bulk, Head of Service in Sensano Cancer Center and Coordinator of OncoNGS PCP. And last but not least, we'll have Yves Verboven, Director and Founder of EU for Health Solutions, who will provide the perspectives of the industry. We'll have a roundtable discussion of 20 minutes, and then it will be Ramon Maspons, Chief Innovation Officer in Aquas, who will be doing the closing remarks. So this being said, I will hand over to Elena Kukarenko.
Good morning. Thank you very much, Ion. Good morning, everyone, again. I am delighted to be present at this very important final event for ANTI-SUPERBUG, this project which has several important aspects for health sector, society, and in Europe. as well. The project has positively contributed to various aspects to the development of ICT solutions for detecting resistant microorganisms or hospital-acquired infections, as well as to control the diffusion of infections within different healthcare providers. All the subjects are of critical importance in the context of the current global pandemic caused by COVID, where rapid detection and spread of infectious diseases control is critical for preventing collapsing of healthcare systems. And importantly, especially in recent years, antimicrobial resistance also became a silent killer and the leading cause of death of some over 3,000 cases per day, with an estimate by 2050 over 2 million deaths per year in Europe, Northern America, and Australia at a cost of around 3 billion euros for healthcare services, which is also very important subject to tackle, given that this issue is causing really increased spread of diseases. In this sense, of course, providing and developing solutions for fast detection and preventing spread of infectious diseases by airborne pathogens is of paramount importance to European health sector and in global context. So to this end, I would like to highlight that regardless pandemic that caused also several disruptions for this project, the consortium managed to achieve several very positive advancements and results. For example, in the area of non-invasive detection of multi-drug resistant organism presence, which was demonstrated in real hospital environment, or also of other airborne pathogens related to COVID SARS particles. It's also demonstrated interest in ICT innovative solutions, which included software and artificial intelligence type tools embedded in system, which help to communicate in efficient and timely manner about the detection and about location of infectious disease, which help to healthcare providers and professionals to tackle this matter in a timely manner and also to prescribe appropriate treatment to affected people. On another side, innovative procurement in public health as an action per se, it's very important action in Europe, initiative in Europe, as it allows to build ecosystems that involve all stakeholders concerned and the complete value chain that are necessary to make this important progress in healthcare system. In this sense, the project brought various key stakeholders together and has successfully decided PCP tendering process in cooperation with buyers group to try or to validate ICT solutions that can be potentially suitable for new product or services. The project also contributed to stimulating cross-border company growth, as consortia from contractors included participants, companies from different European countries, which is also a very important point. Importance of the project was also demonstrated by a recently awarded follow-up project, rather PPI, which will build up on some results coming from ANTI-SUPERBUG, and they will be taken forward, as I understand, to more advanced TRLs in order to provide commercial solutions to the health sector. So that is demonstration that the project subject area and its findings are confirmed. And with this important achievement, I would like to congratulate the consortium. It's indeed very well done. And finally, project activities can be directly linked and relevant to several important ongoing EU policies and initiatives. For example, antimicrobial action plan with aim from a European Commission to introduce revision in EU legislation, pharmaceutical legislation by the end of this year, actually. AMR is on a strategic research and innovation agenda and roadmaps, as well as you are aware of the current candidate for a new candidate of a European partnership under Horizon Europe, One Health Network AMR. And importantly, the subject area tackled in the project remains an important field of EC investments and various mechanisms, whether it is European Innovation Council or Horizon Europe funding opportunities, where ICT solutions for health or AMR field can be seen in recent calls or in some ongoing calls. And you can look at various dedicated clusters, like cluster 4, digital industry and space, where advanced system and sensing technology for healthcare applications can be found. Or cluster 1, health, where among the areas of interventions there are 3 very relevant ones related to infection diseases or healthcare system and digital solutions, and also with some opportunities for tackling viruses, SARS, and AMR. So on this, I wish to conclude, and I wish you to have a very good event and a very fruitful discussion. On this note, I would like to hand over to Ian again.
Thank you very much, Elena. Thanks for your words, for this valuable and appreciated introduction, and also for this brief contextualization of antimicrobial resistance field. So in line with these last words, I would like to hand over now to Marie-Cécile Blois, who is Professor of Microbiology at the University of Limoges, and as well the coordinator of the European Joint Action on Antimicrobial Resistance and Healthcare-Associated Infections, also known as EU Jamboree. So Marie-Cécile, the floor is yours.
Thank you, Jan. Good morning, everyone. Thank you very much for the invitation. I'm delighted to be here with you. And as Mrs. Kukarenko said, I will just share my screen first. Okay. Is it okay? Yes?
Yeah, perfect. So,
as you know, life-saving antibiotics, and it has just been said, the antibiotics revolutionized our society and economy. And as you know, previously, deadly diseases became routine illness, requiring little more than a brief treatment. And these achievements are now at risk, mainly because of the excessive or inappropriate use of antimicrobials. And antibiotic resistance imperils global health now. And as you know, multi-drug resistant bacterial infections account for over 33,000 deaths in Europe, as it has been published by the ECDC in 2015. And at the global level, there is a recent paper in The Lancet showing that there is 1.7 million deaths attributable to AMR in the world. So in this context, there have been multiplication of national, European, and international initiatives against antimicrobial resistance over the last decade. So that reflects a shared commitment to actively tackle AMR. However, these different initiatives worked too much in silos. And there was a need to gather all member states and stakeholders in a same commitment. The objective was to bridge the gap between the declarations and concrete actions. And this is really a challenge that policymakers have to address. So in this context, the European Commission launched a joint action on antimicrobial resistance and healthcare-associated infections. So I coordinated this joint action named EUJAMRI from 2017 to 2021. And the objective was really to foster the synergy among the European member states and to propose concrete steps to strengthen the implementation of efficient and evidence-based One Health policies. So EUJAMRI gathered 44 partners from 26 member states and more than 40 stakeholders, with representatives from European and international organizations, as you can see on the slide, but also representative of the civil society, health professionals, patient associations, actors from the animal and environmental sectors, and different companies. And the joint forces of policymakers, international organizations, and stakeholders is paramount for success in the global battle against AMR. If we work too much in silo, if we work only alone in each member state, we can't tackle AMR at the global level. So EUJAMRI allowed us to join forces and capitalize on our knowledge and best practices in each country to tackle AMR with a One Health perspective. We loved working together, partners and stakeholders, and our collaboration allowed us to achieve significant progress. And we showed, and it is very a major point, we showed that the One Health approach is more than a concept, and that it comes true if we are all committed in the same direction. So we propose concrete steps through policy briefs, aiming at strengthening the national and European responses against AMR and healthcare-associated infections. So you have here the different policy brief, and you can have a look at them on the EUJAMRI website in the results section. However, we still have work to do. So what is left to do? Firstly, we need to acknowledge the importance of communication and coordination through country-to-country visits between European member states. And the EUJAMRI was working towards the implementation of a network of supervisory bodies that will be responsible for coordinating activities related to AMR and for the extension of the strengthening of the mandate of the AMR One Health network. We know that there is another crucial point is the use of antibiotics. And we know that excessive and inappropriate use of antibiotics, as well as poor infection and control practices, are the two main drivers of AMR. So the member states and stakeholders we interviewed consider that having core elements in stewardship and infection prevention and control at the European level is a priority for effective implementation. These core elements should be implementable at national and facility levels, both in human and animal health. And these core elements must be complemented by an evaluation framework with relevant indicators accompanied with quantified, achievable targets with a One Health perspective. And what about surveillance? The EUJAMRI has exposed that there is a gap in surveillance in animal health. And this gap is about diseased animal, as it is done for human surveillance. So we discovered that surveillance of resistant animals is actually fragmented in Europe and heterogeneous, and that there is no European guidance. So therefore, we initiated the establishment of the European network of antimicrobial resistance surveillance in diseased animals called ERSVET. However, this initiative remains at an early stage, and we need to launch a pilot phase to go further. Lastly, antibiotic shortages, as you know, have been increasing globally over the last decade. And as we are talking about antibiotic stewardship, and you are going to discuss today about diagnostic, and diagnostic stewardship is as much important as antibiotic stewardship. And one of the main reasons of the importance of diagnostic stewardship is also to have a more personalized medicine in antibiotics prescription, which will be also another crucial point for also maintain the access to the antibiotics. So, as I said, antibiotic shortages have been increasing globally over the last decade, and we need to identify pull mechanisms at the European level, new pull mechanisms to support antibiotic access and innovation. And for the antibiotics, the new mechanisms for access and innovation cannot be only through public procurement, because it's more complicated for the, especially for the innovation part. So during the joint action, we shared our experiences and evidence-based good practices related to such mechanisms. And this sharing will be really essential in the coming years, and to, at the very least, limit and at the best prevent the serious threat that is AMR for the EU. So we interviewed many countries, and many countries support the implementation of new pull incentive for essential antibiotics, the new ones, but also the old ones. But the member states are uncertain to how to proceed, and they would prefer multinational collaboration. During the UJAMI, we also initiated many communication and awareness activities, which are very important to have all the citizens involved also in that fight against AMR. So one of the actions we created, as you can see here on the slide, we created the first global symbol representing the global threat of antibiotic resistance. And promoting this symbol over the coming years is important for raising EU citizens' awareness of AMR. And we can see on this slide the French Ministry of Health and the AMR lead at the Ministry of Health, and we were very proud that they were wearing the antibiotic resistance symbol. We also developed a toolkit that you can find on the UJAMI website, a toolkit that will enable countries to build their own social behavior change communication strategy. And the announcement of a second joint action on AMR in the recent EU for Health program will now allow us to further progress and implement the projects identified within the first UJAMI with pilot actions and working groups. So at the end, I just want to conclude that working hand in hand will allow us to maximize our resources and improve our impact. Together, we will move forward further and faster to achieve our shared objectives. So thank you very much.
Thank you very much, Marie-Cécile, for this great contextualization, also for these last words to encourage the action on this field. So continuing with the program, I'll share my screen. Hope you can see it properly. Okay. So just following up from the words and from the presentation of Marie-Cécile, we will now present what are the actions that we performed in ANTI-SUPERBUGS PCP project to contribute to tackle the antimicrobial resistance field. So here we will see what are the actions from the very beginning with the unmet needs identification till the end of the pre-commercial procurement in the field testing. So just taking from the presentation of Marie-Cécile, just mention that the project is focused on the antimicrobial resistant field and the multi-drug resistant organisms, which is the mutation of bacteria in response to the use and normally to the bad use of non-proper drugs, which leads to the non-effectiveness of the antibiotics. This, at the same time, has a really bad impact and it leads to different diseases, such as the pneumonia, tuberculosis, septicemia, or gonorrhea, which is affecting 3 million patients every year and causing 50,000 deaths as well every year. Unfortunately, as was highlighted by Elena, Marie-Cécile, these numbers are increasing, and it is estimated that 10 million deaths will take place by 2015, causing more deaths than even the cancer disease. So yes, there is need for action, and we in ANTI-SUPERBUGS, when we started back in 2016 in September, we analyzed that there were two main pillars in the current situation, which were, one was focused on the treatment. There were some great clinical guidelines in order for the healthcare professionals to properly use in a responsible way the use of antibiotics. This was performed through exhaustive training and also through evaluation of these performed tasks. And there was a second pillar focused on the precaution. This is now much more known due to the COVID-19 pandemic, and related with the respiratory infections, we understood what is the relevance of proper hygiene and also the isolation. So in ANTI-SUPERBUGS, we decided to include a third pillar, which was based on the detection, and to have a rapid detection that non-invasively could provide a quick response in order for the healthcare professionals to proceed with an accurate and effective treatment for the patients. So to do so, we built the ANTI-SUPERBUGS PCP consortia, which is built of 6 procurement organizations. We have 2 entities looking after the surveillance of nosocomial infections at a regional level. Here we have the Catalan Oncology Institute, supported by the Nosocomial Institute of Surveillance Program in Catalonia. We also have here the Provincia Autónoma de Trento, representing the Trento region. And then we have 2 university hospitals, which are the University Hospital of Aachen in Germany and the Sheffield Teaching Hospital NHS Foundation Trust in UK. We have 1 private university clinic, Helios Universitats Clinicum in Wuppertal, and lastly but not least, the research foundation linked to a teaching hospital, as it is the Fundació Muta Terrassa. As a supporting entities, we had the Agency for Health Quality and Assessment, AQUAS, that also acted as a lead procurer and acted on behalf of the 6 procurement organizations. We have the Research Institute of Sweden, who made an amazing work defining the state of the art and making a surveillance during the whole project. And lastly, Sarah Bedin, who supported both the preparatory and execution phase of the PCP with their expertise on innovation procurement. So in the preparation stage, which is also known as the phase 0, we divided this in 3 different stages. The first one was the preparation, to have the problem analysis, also the needs identification through different methodologies, and as well as the business case definition. Once we internally had this needs identified, these common needs identified, we then proceed to perform the market engagement with different events. This was before the pandemic, so they were face-to-face. They took place in Barcelona, Manchester, Mulheim, and Trento. So we covered different countries of Europe. And once we had the feedback from the market, we then proceeded with the challenge definition. We defined the procurement objectives, as well as the procurement timeline, and basically the whole innovation strategy. So going to the first preparation stage, the needs identification was made in 4 steps, not counting the step 0, which was the methodology introduction. So once the methodology was defined and agreed, we then proceeded with a problem analysis with different focus groups that were performed locally. And then we went through the WIP-G methodology, that given that we were looking for R&D services that were not still in the market, we were asking the healthcare professionals and different variety of stakeholders, what would it be great to have? So this was quite useful and fruitful. And once we did this needs identification, we had a common needs description and selection with different questionnaires, and also a panel that took place in Trento. We finally defined the business case, which is a key element in the procurement, in the innovation procurement, in order to justify what's the reason behind this innovation procurement action. In parallel, we were defining the state of and analyzing the current state of the art in order to present to the market a credible and feasible demand. As a result of this needs identification, we had 5 different key elements that were defined. The first one is that it was needed a high sensitivity and a specificity solution. So this needed to be accurate. It needed to be rapid as well, and also connectable, interoperable, that it could be connected with the health information systems. It should of course be affordable, cost effective, and finally easy to use, so the healthcare professionals could use it in an easy way and friendly way. So with these demands, we then went to the market and performed this market engagement. The objectives were, first of all, to understand current state of the art, because it's true that we at home made some analysis, but it's true that at the end of the day is the market who will show us what's the current state of the art, to analyze potential barriers that they could already identify, as well as actions that the consortium as a whole could perform to support them to provide a solution eventually. And of course, from our side, it was also interesting and useful because it made our requirement visible and let them know that in the future there would be a procurement taking place. So regarding the calendar, we had the prior information notice published on October 2017, and then the different market consultation events took place at the end of 2017 and the beginning of 2018. In total, we had the engagement and we approached 30 different companies that helped us to achieve the expected results for this phase. The response was quite clear. They saw feasible to create an interoperable platform. However, they identified a big challenge, which was the development of a bacteria detector in real environment, being this non-invasive. Also, when we were requiring a high level of sensitivity. So this was a well-defined challenge by the supply chain, and they also stated that there was limited competition in the field, especially for the SMEs, so that they will very likely need to collaborate between them in order to give response to the challenge. So we took this feedback from the market engagement and readapt our challenge brief. 4 of the 5 pillars that we defined remained equal. So the solution needed to be rapid, interoperable, affordable, and easy to use. However, given that the challenge was to define and to develop a solution that's with high sensitivity, we left this level of accuracy to be defined by the proper bidders and the proper supply chain. So they were going to be the ones that were going to define the level of accuracy of their solution. With this, we proceeded to launch the tender, which was, with the volume was almost 3.5 million. The 70% was co-invested by the European Commission and the 30% by the buyers group, composed of the 6 procurement organizations. And as mentioned previously, Aquas acted as procurement entity on behalf of the 6 buyers. The tender was launched on July 26th in 2019, and it was planned to to remain open for 60 days and to leave to the potential bidders to have 60 days to present their offers. However, given the answer that they provided, that they will need some time to collaborate and to find suitable partners to give a response, we left 30 more days. So in total, it was 3 months opened in order for the supply chain to present their offers. So just don't get too scared with this slide. Just we will explain it little by little. Moving to the left side of the screen, all the different preparatory tasks that we just described are compiled in the phase 0, that could be also known as the curiosity-driven research. And then it was the call for tender that was launched for 90 days. So in our PCP framework, we defined that 4 contractors would sign contracts for the phase 1 as well as for the framework agreement, which covers the whole PCP spectrum. So those contractors that satisfactorily and successfully performed the phase 1 contracts, they were going to be invited to present their offer in phase 2, which is based on the prototyping. Here in phase 2, they needed to develop a solution that could work in lab conditions. And here in this case, this was a little bit longer. The phase 1 lasted 10 weeks, the solution design, while the phase 2 lasted 20 weeks. And the maximum contract volume in this case was 360,000. In the same manner, those contractors performing satisfactorily and successfully their phase 2 contracts were going to be invited to join phase 3. And in this case, again, there will be 1 contractor that wouldn't be invited to sign contracts, as the number of contractors is being reduced, until the phase 3, where the aim was to have 2 final contractors proving their developed solutions in lab conditions and to have them proved in real context. In this case, we left 34 weeks, and the maximum contract volume was 726,000 euros. So this is how we defined the ANTI-SUPERBUGS PCP framework. And going back to the call for tender stage, we will be honest, we were a little bit frightened and scared because we were frightened to launch perhaps a too ambitious challenge. So the result was very successful from our point of view, as we have 6 different bids composed of 5 consortiums, as it was more or less estimated and could be foreseen after the market engagement. So it was 5 consortiums and 1 individual bidder. The consortiums were built 1 of 2 companies, 2 consortiums were built of 3 companies, 1 consortium was built of 4, and lastly, 1 consortium was built of 5 companies. In total, it was 18 economic operators that participated in the call for tender. They came from 5 different countries. In total, we had 11 SMEs participating, as well as 7 research centers. Also important to highlight that the 6 consortiums were led by SMEs. So as a result of the ANTI-SUPERBUGS PCP overview, here you can see the 4 contractors that successfully signed phase 1 contracts. As observed, we can see that they were built up of 3 SMEs and research centers. So in total, 9 SMEs and 3 research centers signed a contract in ANTI-SUPERBUGS PCP. And lastly, it was the case of Backwatcher and Sense4Care, who successfully got to sign phase 3 contracts and prove their developed prototypes in real context. So we will make no spoilers, and we will leave Backwatcher and Sense4Care to present the results. But basically, to describe the phase 3, here again, they needed to prove that their developed solution worked in real environment. And we put it in a real challenging way, because we defined the phase 3 in a way that they needed to prove that the solution worked in 3 different pilot sites from 3 different countries. So here, first, they needed to set the test series of solution ready for testing, obtaining favorable ethical approvals in Spain, Italy, and Germany. also working in the shipment and installation of the devices in these locations, which were on the Rovereto Hospital, Healthcare Trust of Autonomous Province of Trento, the Helios University Hospital in Wuppertal, and the Mutua Terrassa University Hospital in Terrassa, Catalonia. They trained the staff of these pilot sites, and after the needed administrative agreements, they started with the clinical proof of concept. Here we defined the research protocol to first proceed with a diagnostic tool, having the comparative study on positive and negative patients, and then afterwards in a screening tool. Consecutive patients enrolled at hospitals admissions. Lastly, they also needed to test the environmental sampling and monitor the inanimate environment surrounding the patient. So again, the results will be presented by each of the contractors, so not information will be provided now. And just to finalize with some of the results of the project communication activities, as we aimed and think that we achieved to increase the impact of innovation procurement and of public procurement as a tool to foster innovation in fields of interest, as it could be in antimicrobial resistance. As also highlighted by Marie-Cécile. We got to approach more than 800 targeted stakeholders, divided them in management positions of healthcare providers, also healthcare professionals and researchers, contracting officers from public administration, and also master students from different universities. Of course, we also approached technology providers, supply chain representatives, in order to let them know what's innovation procurement about and what are the benefits of participating in this kind of innovation procurements and these procedures. With the results achieved, we also got to raise awareness in the scientific, healthcare, and research community with regards with the ANTI-SUPERBUGS project outcomes. So we got accepted an oral presentation and a poster in the 32nd European Congress for Clinical Microbiology and Infectious Disease, which is taking place in Lisbon, Portugal, pretty close, in less than a month. We also had a poster accepted in the Italian Microbiology Congress, the National Congress in Italy. And lastly, we also had an abstract accepted in the European Health Management Association Congress that is taking place this June in Brussels. We also applied for the 45th World Hospital Congress in Dubai, which would be a great asset to present the project there. And lastly, we are now working on different open access scientific publications in order to let the scientific community about the results of the project. And just to conclude, as a major result of the implemented exploitation activities in ANTI-SUPERBUGS, it was achieved that a cross-border bias group, which is composed of 4 different procurement organizations, committed to collaborative work in Radar PPI project, which is a project that started this January 1st. These procurement organizations come from France, Spain, and Italy. So we somehow ensured that these achieved results and impact will still evolve in the following years, with this project contributing as well in the antimicrobial resistance field, again, through innovation procurement. So this is not only a great asset for us. This being said, just thanks for your attention. Now we can move to the next block, which is based on the resulting novel solutions. So from now on, I will hand over to Backwatcher Consortium, which is going to be presented by Ana Genova, Joan Escudero from Grupo Pulso, Stephen Daniels from New Wave, Daniel Quesada for Paper Drop, and lastly, Wolfgang Vautz from Ion Gas. So great team presenting. So now the floor is yours.
Thank you very much, Jon. So let me share my screen so that you all can see our presentation. and let's begin. Okay, so like Jon said, I'm Ana Genova. I'm the project manager leader of the Bugwatcher solution, one of the 2 successful bidders in the overall PCP. I will be presenting with our colleagues from the consortium, who will be presenting themselves when they present their companies, our solution and our steps in the different phases of the PCP. Okay, so let's begin, like I was saying, with who are we? So basically, which are the entities that are composing the consortium in the terms of who are the ones that are composing the consortium and who are the companies that we must take into account as subcontractors. The consortium of Bugwatcher is divided into 3 different companies. It is led by my company, Grupo Pulso, which is established in Spain. And we also worked with the collaboration inside the consortium of wave sensors and paper drop diagnostics. But we also want to highlight the subcontractors we've had in the overall PCP, and especially our technological partner, who was a subcontracted company, Ion Gas, established in Germany. And then the 3 different CROs that were also involved in this 3rd phase, in phase 3, and that helped us through the leading of the Spanish CRO Dynamic, throughout all the process of submission to the ethical committees and pilot study in the 3 countries of the buyers groups. So I will leave the word now to my colleague, Joan, who will explain a little bit more about our company.
Okay, thank you very much, Anna. So as Anna mentioned, we are a Grupo Pulso company, which belongs to the Evidence Group, which is a group that has offices in Portugal, Spain, and Italy. Our headquarters are based in Madrid, and we have more of our staff split between Barcelona and Madrid. Our group basically have 4 main activities. One of them is clinical trial, clinical studies. Second activity is continuing medical education, especially for healthcare professionals. Also, we do patient support programs addressed to patients in order to increase the adherence and support on their daily disease management. And last but not least, we have a digital transformation unit where Anna and I belongs to, which take care of the e-health based projects. Basically, all of these business units have a common single strategy, that is to bring scientific knowledge into clinical real world practice. And then we use these 4 units, or these 4 triggers, activities, to achieve or to work on this aim. So basically, finally, we help, as we said here, our clients to cope with the changing environment, basically through research, I will say, through clinical study innovation and knowledge in health. Next one, please. So, and basically our overall view of what we do and how we implement or how we contribute to the global health ecosystem. Basically, we are a partner that complements, improve, add different type of services to existing products on health. And when we mean products, we mean pharmacological products for pharma, but also medical devices. Okay, in pharma, we can think about companies like, I don't know, GSK, Novartis, Pfizer, and so on. And on medical device, we can think about people like Medtronic, Philips, Abbott, Johnson & Johnson, and many others. So we work a lot with these companies, which were traditionally our providers, and then we move to our partners with them. That means that we complement most of the services which I just mentioned, which means consulting, training, digital tech, e-health developments, and home care, and all these services. And then we add, and then with that we have an add value solution. But this is not enough. We have to provide a results-driven proposal, core proposition, and in that, through our CRO knowledge, we include also how we measure the impact of the product, and with these services together with our partners, I will say, rather than our clients. And then we bring this to a result, and I would say kind of risk-sharing propositions that we have been quite successfully applying to several PPIs tenders as in the last couple of years. So, Stephen, I think the floor is yours now.
Thanks, Joan.
Yeah.
So we are New Wave Sensors, based in Ireland. There's about 20 people, and we are experts in sensing and environmental monitoring platforms we had huge benefits from participation in this project. It allowed us to develop a derivative of our devices for monitoring for air contamination. Specifically, we developed the Lumer molecular product, which uses a nucleic acid method for the detection of specific microorganisms in the air. And we continue to develop this in with our partners on in our project. Thank you. Over to Daniel.
Thank you, Dr. Stephen. Paper Diagnostics is a Spanish small-medium enterprise that deals with non-covered medical needs and emerging health problems, developing rapid diagnostic tests. You may recognize our technology, the lateral flow assays, from the SARS-CoV-2 or the pregnancy test. Ours is an adaptable platform. We can use different bioreceptors for their recognition, like antibodies or DNA. We also can recognize different types of targets, like viruses, bacteria, antigens, microRNA, and even small molecules or wall cells. We have our own proprietary nanomaterial, which improves the sensitivity of the system and decreases the detection limit. Now I give the word to Dr. Baus.
Thank you. So we are a small enterprise located in the western part of Germany, in Dortmund, and we are focused on the development of tailor-made devices. And these devices are based on GC-1 mobility spectrometry. And this method enables rapid non-invasive detection of trace molecules in really complex gas phase samples, which human breath is a perfect example. So what we do is method development and sampling development. Here you can see an example of bacteria culture, and above the photograph you see a pattern of volatiles we detect from such a culture, and the pattern are characteristic for the sample and enables pattern recognition to characterize the sample. And we can do this with such mobile instruments, which you can see on the photograph. And this is more or less the same instrument with different experimental setup, which we gave to the hospitals included in the consortium. This is not only possible for bacteria, so we have several successful applications, such as quality control in tire production, quality control at hydrogen fuel stations. We can detect drug abuse, as well as hidden persons in a container or trailer lorry, for example. So that's from my side. Thank you.
Perfect. Thank you, everyone. So now that you've known us and we've been able to explain who we are, we would like to describe what is the Bugwatcher solution. So which is this solution that we've been able to develop within the scope of the PCP procedure. We first want you to visualize our solution with the scheme that you can see on screen. So basically, the Bugwatcher solution is divided into 3 different screening devices that can detect the contaminations from the 3 target bacteria. They can assess the infections in fomites, as you can see in the above left side of the scheme, in humans with the 2 methodologies that were presented by Daniel and Wolfgang, and in the air of the surrounding environment technology, which was presented by Stephen. So with all of these contaminations detected, 2 of which are the breath screening device and the air monitoring device, connect automatically with Bugwatcher's professional station. Healthcare professionals can consult on demand and can see in real time which are the infections that have been detected and which of those are still activated or are still active, and they must be solved. So basically, the Bugwatcher solution is divided into these 3 screening devices and an ICT platform composed of a website platform and a mobile application addressed to healthcare professionals for them to be able to identify in real time and to prevent spreading of infections by the superbugs. Okay. As I explained, both the air monitoring device and the breath screening device are connected automatically with Bugwatcher's web server and the database and the overall software. So we can visualize in a real user-friendly way the infections that are presented and in order to register the infections gathered from the cassettes, from paper strips screening device, what we must do is we would ideally use the mobile application and we would take a photograph of the cassette, which works, as Daniel explained, as a rapid diagnosis test that we've all seen with the antigens tests for COVID. And we would take a picture and we would mark in naked eye, which has been the result that we've identified by naked eye, And this will also be shared with the healthcare professional station. So basically, when healthcare professionals want to see which is the situation at their hospital facilities, what they would need to do is register in the ICT platform and just visualize which have been the infections identified, which of those are still active, and which of those they can address at one moment. To complement this explanation, we also want to show you a video because we've been able to record the Bugwatcher solution installed in the real hospital environment of Hospital Fundació Mutua Terrassa. So let me change the screen and let's all of us see the video. I hope you enjoy it.
Let's take a deeper look into the Bugwatcher solution. The innovative tool is composed of 3 screening devices and an ICT platform, which gathers the alerts coming from the devices and presents them to the hospital staff. The screening devices are able to assess any potential infection from 3 superbugs in humans, in the hospital inanimate fomites, and in the air of the surrounding environment, for detection of the target pathogen in patients using the MVOC device. The healthcare staff should prepare the machine and initiate a new patient breath sampling process. The patient needs to breathe in the mouthpiece for as long as the machine indicates, and the MVOC sends the result automatically to Bugwatcher's cloud. If the clinician uses lateral flow strips, they must gather a nasopharyngeal sample from the patient using a swab and, using the extraction buffer included in the LF kit, place a drop in each bacteria well from the cassette. If no bacteria is detected, only the control line will appear. If the detection is positive, both test and control lines will be visible. The procedure for the detection of the bacteria in fomites consists in gathering the fomite sample with a swab and performing the same steps as with the human sample on the LF cassette. For environmental airborne pathogen detection, clinicians can use the LUM Air. The first step of sample gathering is to upload a new cartridge in the LUM Air and run a new test. The process takes around 90 minutes to finish, and the result will be sent automatically to Bugwatcher's cloud. When a detection is positive, the Bugwatcher ICT platform alerts healthcare professionals for them to manage the infections and avoid spreading. With Bugwatcher, clinicians can log in on demand and check the current hospital's infection status.
Okay, so back to the presentation. We hope that with this video, you've got an idea of what Bugwatcher does and what it is composed by. So now moving on to which have been the activities that we've performed in the overall PCP, and especially highlighting phases 1, 2, 3, which are the phases that we are currently finishing. Phase 3 is the one that we're currently finishing. So let's begin with phase 1. As with every PCP, phase 1 of this type of public procedure consists in the solution design and feasibility study of the overall proposal that was presented in the call for tender. For us, this has implied that we've been able to design and define the Bugwatcher solution, including these 2 screening devices that were presented, the LUM Air and the lateral flow strips, and the ICT platform. More precisely and specifically in the LUM Air technology, we've been able to identify the detection method and design architecture of the system. In the case of the lateral flow strips, we've been able to identify the 3 target proteins, one related to each bacteria, that would be detected by the lateral flow paper strips. And concerning the ICT platform, we also were able to design the software architecture and Bugwatcher's interface. As Ion explained in his presentation, we managed to be satisfactory and successful in phase 1 and were invited to participate in phase 2, being also successful and moving on to the second phase, which has basically consisted on the prototype development. So basically what we achieved with phase 2 was a ready-to-test working prototype that could improve the quality of care processes in the hospital and the reduction of costs and collateral effects caused by these known multi-drug resistant organisms. Specifically, regarding the Lumiere technology, we were able to perform a nucleic acid assay development and hardware prototyping for testing. Concerning the lateral flow strips, we also were able to prove that the 3 bacteria could be detected in a laboratory using the reference strains from CE/CT. And finally, considering the ICT platform, we also validated the mockups for both the application and the website of Bugwatcher, and we were able to develop the overall ICT solution, integrating the automatic communication with Waves Cloud. As you can see, we were not able to include IonGas, the 4th technological company that composes our solution, until phase 3, which is the phase that we'll be explaining now. So basically on phase 3, we included this new partner and this new subcontractor in order to improve the value of the overall solution. And basically, we've divided phase 3 explanation into the milestones that we've achieved and then the results from the pilot study. So for our case, we were able during this phase 3 to submit to the ethical committees and competent national authorities of the 3 countries that are implied in the PCP, so of Germany, Italy, and Spain. We also obtained the approval of the Spanish Ethical Committee, and we began and performed the study pilot in Hospital Fundación Mutua Terrassa here in Spain. As for the pilot, given the complexity and given all the challenges that we've encountered, basically provoked by the SARS-CoV pandemic, so the COVID-19 pandemic, we've been able to recruit a total number of 31 patients, 30 of which were negative from any of the 3 target bacteria, and 1 of which tested positive from Klebsiella pneumoniae. We also were able, as we explained, by the inclusion of this new technological partner, to design and develop a non-invasive breath-based system, which is called the MVOC detector that could detect the superbugs, thereby augmenting and improving the Bugwatcher's potential. And finally, we also began with a first approach in commercialization activities with some agreement with private companies and private partners that we'll be explaining in some minutes. So concerning the main results, we want to focus the results in the study pilot in the Spanish hospital, which has been the hospital where we've been able to test our technology. So we want to highlight these 3 key points because we think it's important. One true point that we also want to mention is that we haven't, unfortunately, been able to test the solution with a large number of subjects. So the pilot study has not gone as planned concerning the end of the research protocol and the end of the study pilot. But it is true that we've been seeing, so therefore this has meant that we're not able to give conclusive results or to give significantly or statistically significant results. But we can see that there are some results that gives us some positive hint of what could happen with our solution. These are the ones that are presented in the screen. It's true that with our technology, lateral flow strips have been able to detect Klebsiella pneumoniae in this patient that tested positive in agreement with the gold standard methodology. So this proves, and all the negative results were also in agreement with the gold standard method. So this proves that we're on the right track. Then another result that we want to highlight is concerning the turnaround time of the Bugwatcher solution, which was calculated and gave a total number of around 118 minutes. So this means 1 hour and 51 minutes to obtain a result. And this is significantly lower than what we are achieving with the gold standard method, which is of 75 hours duration. So we could say that Bugwatcher is definitely faster than the gold standard methodology. And finally, concerning something more of quality of the solution, it's true that from the feedback we've gathered from patients, we've seen that patients preferred our solution against the gold standard methodology. More specifically, as you can see on the graph, a total number of, or a total percentage of 75.9% preferred the bug-watcher solution. There were no subjects that preferred the gold standard methodology, and there were a 24.1% of subjects that had no preference method. So we can say that patients are satisfied with the solution and that the solution is definitely faster. So we will move now to the outcomes of the anti-superbugs PCP for bug-watcher, and this specifically consists on explaining the public exploitation activities. I leave the word to Joan.
Yeah, thank you. So we have been starting already some business activities some months before we end the phase 3. So with our, I would say, extremely serious commitment, or we really believe that this is a very valuable solution to the health ecosystem, and we definitely start internally to approach some potential customers and partners at the European space. The first thing is that we want to emphasize that bug-watcher is an ecosystem of solutions, as you have seen, a different type of equipments and devices, an ICT platform that really provides or can conform with a flexible solution that meets the customer needs. The second thing is we have defined an MVP composed by the Lumer and ICT platform. And then we have been approaching, as you can see here, different companies, as I said, from the medical device and from the pharma industry as our partners to address different health institutions, which at the end it's the end user of the solution, to contribute to help them to generate awareness of the bug-watcher as an innovative solution on the disease management as a whole. So we have been having different meetings and even presenting different type of economic proposals, which is at the end of as of today on a contract discussion with some of the companies you can see listed here from Spain, Germany, and even Mexico. Because we, from Pulso, we have an office in Mexico, and from there we have also explored the Central and South American markets as of today.
Perfect. And finally, in our presentation, we also wanted to highlight a little bit and explain which have been the lessons learned, the next steps that we've seen with the presentation. So basically, concerning the lessons learned, we want to highlight the following two. The first one has been that an efficient communication between the buyers or procurers and us as contractors has been a key success factor, especially with the difficulties that we've been mentioning that were derived from the coronavirus pandemic. It is true that we want to highlight that all the procurer entities, and especially Aquas as lead coordinator, has helped us a lot with these efficient communications, and this has allowed us to prevent and to try to mitigate the possible risks and the possible things that could happen or complications that we've encountered. As a second point, we also think that there's this need to work closely in advance with the CRO type of companies, with the CRO companies and with the pilot sites, and this could allow to shorten the pilot study time approvals. This has also been another challenge for us. The long time that is expected to obtain certain approvals. So this working closely, which has already been done in this PCP phase 3, but still working closely in advance. So maybe even starting in phase 2 with the discussions and conversations with the CRO and pilot sites could also allow us to shorten these times that we encountered. And finally, which are the next steps that we envision? So what's next now that the PCP has finished? Well, first, this PCP has allowed us to identify this real unmet need across Europe and even worldwide. And this has allowed us and will allow us to develop new business lines, definitely. We've also been able to know each other, so the companies composing the consortium, and to know the companies that compose the buyers groups. So we are able to maybe try to think some other routes and of collaboration between us. And a second point, we also want to highlight what my colleague Joan just mentioned, so that we are in the process of evaluating a potential purchase from the procure sites and with these discussions with private entities. So let's see how this evolves, but we are optimistic and we really believe in our solution that could impact and change the life of patients and healthcare providers. And finally, in line with what we've mentioned, what we want to do now, or our idea is to try to implement the feedback that we've gathered from the end users of phase 3 in order to be able to improve our backwatcher solution. It's true that with this PCP, and especially with this phase 3, it's the first time that our solution has been tested in a real environment, and it's the first time that it has been tested with real subjects. So we will try to gather all this feedback and to try to include it and incorporate it and be able to improve our backwatcher solution. So thank you everyone for your attention. This was what we wanted to present. And I leave the floor to Ion, I think, or directly to the other contractor.
Yeah, thank you very much, Anna, and all Backwatcher Consortium. Thank you very much for this great presentation describing all the pathway along the PCP. So congratulations. And needless to say, really great video with your staff working, acting as patients. So thanks. In Mutua Terrassa, this was great.
Thank you.
So it's time to move to Sense for Care Consortium to present their solutions. So here we have Carlos Chiati from Tech for Care, as well as Silvia Gomez and Marc Collado from Sense Solutions. So Sense Solutions, Sense for Care, the floor is yours.
Thanks. I think I am already sharing my slides, and I hope you can see them. Well, first of all, thanks very much for everything, for the organization event, but most of all for the overall management of this very complex project. We've been very honored to be part of the process, and we will try to squeeze into this 20-minute presentation our experience and the work done so far. We will be doing this by introducing quickly our consortium, describing the solution which we proposed to this very challenging request for tender that was issued some times ago already, and our journey through the 3 phases of the project, trying to highlight you how from an idea, which was only a paper-based, so was coming from literature review and experience of the partnership, we've been able to produce and test a prototype, which will be presented now. Before, of course, showing you what is our next plan for the future, we will go through the outcomes of the project for us and the lesson learned. So, first of all, the challenge, as you mentioned, was very demanding, as we were requested to go beyond the current method for assessment of of bacteria detection in the hospital. Going beyond meant mostly going beyond the current culture-based methods, so that we needed to provide the buyers with a solution which could provide the continuous detection monitoring of the hospital environment, an effortless assessment. And for that, we needed to partner across countries. And so Tech for Care, which is mainly a digital company with, of course, also departments that are specifically dedicated to the project management and to the all the activities, support activities that are typically required for fast prototyping in the medical device environment. So all the expertise and knowledge to provide basically an idea with the basic certification and regulatory compliance required to go to the field. We are a company that is based in the Marche region, and mainly we detected the opportunity of the call, but we needed to get in touch with the company who had the correct vertical knowledge for providing this innovation in the detection of hospital infections. And to do so, we partnered with Sense Solution, that is now represented at the moment by Silvia, which is a Barcelona company with a specific expertise in the area of bacteria detection. So Silvia, please.
Thank you, Carlos. So Sense Solution is a company born with the mission to change the world, taking into account that air and water are essential elements for life. At Sense Solutions, we work on, the work is focused on producing the disruptive change in the way of monitoring the quality of water and air and avoiding compromising situations for the health of living beings. Our background allows us to develop disruptive devices to monitor the presence of bacteria in both water and air, using the latest generation of miniaturized sensors and artificial intelligence techniques that together give a differentiated added value. Sense Solutions is located in the research park of the Autonomous University of Barcelona and has the seal of innovativism. Well, during 2022, we are working on bringing the developed technology to other sectors such as agri-food and children's health through two European projects in child health and agro-3DP. Next slide, Carlos.
I think the next slide is the slide describing our solution. We want to start with a quick video just because the video has the possibility to give you immediately the full overview of how the solution works. And then we will go into the
Welcome to your SENS City, a sustainable smart city. The SENS IoT Cloud is the neuralgic centre of our company. To answer all our customers' needs, we use the most advanced security systems. At SENS Solutions, our property-owned sensors system ensures our data quality. In a global economy, we all have different needs. At SENS Solutions, our products are adapted to improve people's health and well-being. SENS for Care detects and identifies the presence of bacteria. It monitors particles, temperature and humidity, among other air quality parameters. This system is available in two versions, with or without a screen. SENS for Care is ideal for high-risk bacterial contamination spaces. It is designed to comply with the required regulations in operating rooms, infectious areas, etc. SENS for Care may be integrated with any clinical management system in a secure way, guaranteeing confidentiality. SENS for Care, solutions that make sense.
So basically, when we first met with our colleagues at SENS Solution, we thought that was a sort of science fiction. But during the project, we've been able to actually prove the concepts that we proposed in phase one. And we basically managed to produce a solution which is based on combination of hardware and software, and that can detect and screen the air on a continuous basis for the detection of bacteria presence. How we do that? Basically, the solution is composed by a hardware part, which is the sensor that the device that you are seeing now in the slide. The device is based on Raman technology and spectrometer, which is continuously screening the air and is, so to say, taking picture of the air. Not to detect, and please, Silvia, feel free to jump in, not to detect the presence of bacteria themselves, but the presence of volatile organic compounds that are associated to the presence of bacteria. This was a proposal we made in phase one based on the experience of the solution and on upcoming literature results, which were showing how the improvement in the technology in the field of spectrography was opening up new possibilities for this kind of real-time detection. So the device that has been developed by SENS Solution is composed by a Raman spectrometer that is integrated into a connected device. So it's able to screen or just after plugging the device into the electric Plug is able to screen continuously the air and perform already a first-level machine learning analysis on the device itself, but at the same time sending the data to the cloud where all the raw data related to the environment which is screened are stored and analyzed continuously. The device is available with the screen that is giving immediate alerts, or can be, as in the picture in the video described, blank. The device, of course, it's part of a network of point of assessments. So basically, we needed to first design and then develop a platform which was integrated to the devices and managing the data coming from the devices, both in terms of detection risk, which was observed after running the first level machine learning analysis, and in terms of management of the possible alerts. So at Tech4Care, this was our role. We developed a platform which was able to manage the detection within the more complex process of care. How we did that? It was a very challenging journey, and I think now Mark is going to give us already a few insights on the research which was needed to reach the point.
Yes, thank you, Carlos. Well, in the phase one, what we do is analyze the technical and scientific feasibility of our idea that was beginning only theoretical and was really an experiment. It was mixing spectrophotometry and machine learning. And also we planned the experiments that we will do in the next phase. Next slide, Carlos, please. In this second phase, we carry out the experiments proposed in the previous phase, growing bacteria and analyzing the VOC, the RLS, using the spectrophotometry. What we find is usual problems on the labs. Next slide, please, Carlos. We collect more than 5,000 scans or spectres, and we apply the usual mathematical processes for spectrography data and feed various types of neural networks with them to see if we could distinguish the bacteria or the white. And next slide, Carlos, please. The results were very, very positive. We are being able to differentiate clearly the presence and the non-presence of bacteria and well identify each one of the bacteria. It should be noticed that these experiments were in vitro. It's in the most ideal conditions. That's all.
Thanks, Mark. Thanks, Mark. So basically, in phase one, we designed it. In phase two, we did the basic research, and we were able to screen and detect in lab condition the presence of bacteria which were grown in lab environment. So strong, so to say, of these very promising results, we moved to phase three. Phase three, it was a very challenging phase. In 8 months, we had to go through the approval, the setup, and the performance and implementation of 3 parallel studies. That was a very smart move by the procurers, because we didn't apply to ethical committee having a leading center, but 3 single center study, and that was the possibility, the key factor that allowed the performance of the study in all the 3 countries. We needed to involve 2 CROs. We obtained 3 ethical approval in the 3 countries, and since the device was potentially considered as a medical device by the ethical committee, we needed to go through the 3 national authorities, and we obtained the authorization to perform the study. Then we managed finally to go live in all the 3 clinical sites, and also to achieve a very good level of completion of the studies, thanks most of all to the collaboration of the procurers. That has been fundamental, because basically in that 8-month period, we managed to recruit over 120 patients in both study 3A and study 3B. So study 3A was the study where we had to first sample the patient and recruit the known positive patients to compare them with the negative ones. In phase 3B, we were using the device. We used the device as a screening device. So just in the hospital and recruiting all people admitted to some selected wards. The performance of the study was possible thanks to the dedication of the staff at the hospital, which was amazing, but also thanks to the dedication of the 2 CROs that we were involved. We are showing you some preliminary results because database closure is in progress. The CROs are still working to clean the data, but still, I think the main messages can be conveyed to you today. We've been able to recruit patients with either an infection or a colonization of Klebsiella, Clostridium, and MRSA, which is for us very important because we've been able to place and use the solution next to people with known positivity. In addition, we've been able to also detect patients and include patients with other microorganisms, which is also very important for us. Why I'm stressing this part? Because as Mark suggested, we only use the system in lab condition first. So with us, for us, it was, of course, a big disappointment, but yet not surprised that condition in the lab and condition in the real life were not identical. So while we've been able to, of course, perform a very quick detection in terms of turnaround time, because the system is taking picture of the air and analyzing a point of detection, while the solution was, of course, considered very acceptable and used with satisfaction by the staff and the patients, we didn't manage with the algorithms used in lab condition to detect successfully cases in real life. But this, of course, it's disappointed, but not so much, because basically the possibility of having this huge database of scans and clinical characterization of each patient is for us very useful as we are moving on and continue to develop the solution, because the neural networks that are used and developed by Sense Solution can be now retrained and redeployed to gain higher sensitivity and specificity. So we are very much working on this now recalibration of the algorithms. The IPR coming from the project are very valuable, and at the moment are protected via industrial secret, as the neural network are the main asset that arose from the project. They are protected by the IP protection clause that is designed for the future commercialization, so that the product will not be sold but will be rented. This is part of the business plan that we designed, and via protection of the trademark. So Sense for Care will be a protected trademark in the future. The business model is basically that of the hospitals. There is no need to go beyond this, but just for you to understand that the solution is expected to be rented, and willingness to pay has been identified to be around 25,000 euros per year, with the monthly fee of 2,400 euros, which includes the license to use one sensor that can be, of course, increased depending on the number of sensors. At the moment, Sense Solution is already working to test and further adapt this solution in the Hospital de la Paz in Madrid, where they are discussing the possibility for a second deployment. Regarding the lesson learned, it has been, as I think I managed to show you, a very complex process. So there are many lessons learned. I've been already showing these slides in the past, and during the project we needed to learn and strengthen a lot of our knowledge regarding the Horizon 2020 rules, privacy. The MedDev regulation was very, very important to conduct the process, and we did it internally. the possibility to carry out fast prototyping. As you have seen, Mark and colleagues have been developing hardware from scratch, which is already very challenging, and it's only a part of the challenge. The capacity to work in multicultural context, the research methodology. But if I have to say the most important lesson learned is that it is very critical to jump from the lab to the reality, and to stick very closely to the original protocols when things are developing so fast. So to say, in other way, basically, for us, it is clear that the trial will be very useful in terms of the data collected, but probably a deviation from the protocol would have been very beneficial in the moment in which, for us, it became very soon clear that the most important part was to have data from positive patients. But of course, it's difficult to know things in advance. Communication with the buyers was anyway the secret for success. Now, just a last slide. I leave the floor to Silvia for the next step.
Thank you, Carlos. Coach. ¿Qué ha pasado? He caído. Qué bien.
We see you, Silvia.
We see you, Silvia.
Okay. I don't know where I put the screen. Well, I see here. The technology has been tested. Volatile organic compounds are differentiated from non-metabolized bacteria in air. This makes it possible to differentiate between colonization of areas and infection in people. The need for clinical study for neural network training with metabolized volatile organic compounds in humans is demonstrated. Therefore, the logical steps to follow are clinical study to train the neural network with volatile organic compounds expelled and metabolized from infected patients. Hospital surveillance service, extending this study with fungi and other bacteria and other diseases in which patients need metabolized volatile organic compounds, such as cancer or virus-infected patients. Broaden the sectors of scope, such as animal health and the agri-food sector, vegetables, fruit, meat, fish, to avoid the loss of food. And finally, but not less important, proceeding dissemination. And the next July, we will go to the FIME. It's a Florida medical exhibition. It's one of the most important exhibitions in America. And next step, next slide, Carlos. I don't know what is the screen.
It's about thanking everybody for, and most of all the buyers and all the clinical staff that have been part of the journey, which was short, intense, and at the end partly disrupted by the COVID outbreak. But in our experience, all the difficulties actually connected to COVID have been strengthening our intention to perform the project, and have probably also increased the willingness to participate to the study by the clinicians, because we felt like being part of a same challenge, even more because of the very difficult situation. Thanks for your attention.
Thank you very much, Carlos, Silvia, and Mark, and congratulations, honestly, for all the work that you have been performing along the PCP. It's been great collaborating with you as well as with Backwatcher Consortium, so thanks, honestly. So now it's time to have a break. It's true that we are running a little bit out of time, so if it's okay for all of you, we will come back at 10:45, and then we will compensate these 5 minutes during the next presentations, but we can have a 10 minutes break and see you back in 10 minutes. Goodbye. Okay, so hello again, everybody. So now let's move on with the buyers group insights. Let's see what each of the buyers groups, what are the reflections, their lessons learned, and their experience in the overall PCP preparation and execution, and also focusing on this phase 3. So we will start with Ana Álvarez from the Institut Català d'Oncologia and also part of the nosocomial surveillance program in Catalonia. So Ana, the floor is yours.
Thank you very much, Ian, for the presentation. And good morning, everyone. It's great to be here in this final event today. And it's a great opportunity to present our institution and our insights into the project. So I'm Ana Álvarez Fernández, and I'm project manager here in ICO, in the Catalan Institute of Oncology. So in a very brief way, so that you can know a little bit more about our institution, the Catalan Institute of Oncology is a public non-profit center working almost exclusively in the field of cancer. It's the cancer center now for almost the 45% of the adult population of Catalonia. And its approach to the disease is comprehensive, combining all-in-one organization, prevention, patient care, training, and research. It's structured as a network. It comprises 4 centers, these 4 centers here, and works in cooperation with also university hospitals, non-profit health research institutes, and universities. And we are specialized in different research areas, and one of them is the healthcare-associated infections area that is directed by the VINCAT program from where we work. And this program is in charge of the ongoing epidemiological surveillance of healthcare-associated infections and also surveillance in antimicrobial resistance in Catalonia, in the whole region that has a population of 7.5 million, and it comprises 73 hospitals, also primary care teams and long-term care centers. And so we are specialized and have experience in infectious diseases and in antimicrobial resistance. Regarding the antimicrobial resistance problem, from our perspective, it continues to be a problem that compromise lives, especially in oncological patients. And in the last year, specifically in our region, we have increased the quality of the records, and we have data from the entire territory that shows that this problem that we have and that is increasing. In this case, I show you an example of a map that is made here in VINCAT, where we can see the percentage of resistance, in this case of this ASBL, Klebsiella pneumoniae, in urinary infections that range this percentage of resistance from 6 to 16%. So the numbers are high, and we have a specific problem here. Therefore, AMR continues to be a health problem in our region, and the forecast is that incidence will increase in the coming year. And for this reason, we believe in the importance of betting in innovation in the search for solutions. And regarding the insights on the overall anti-superbugs procedure, in the preparatory phase, we have led the work package 2 that consists in the need assessment. And the overall objectives in this work package were to perform a need assessment to identify and verify a cross-border common need among healthcare organizations, to develop a business case with an opportunity cost estimation as well as benefits analysis, and in parallel with the state-of-the-art analysis, transform validated needs into ambitious but credible requirements that the market operators can respond through a challenge brief. And finally, the minimum needs that all the teams together decided that the solution had to meet. Where these 5 here that already have been mentioned by Jon, is to be accurate, to be affordable, to be rapid and connected with the systems, and easy to use, and minimally invasive for patients. And regarding the execution phase, we've been committed ourselves with the projects, and we have been because we are confident in the need to address the fight against antimicrobial resistant organisms. So the Catalan Health Department have been the purchasing partner with the largest investments, since we were confident in the momentum that this project will provide to promote progress in this field. And regarding our role in the execution phase, we were present in the tendering board, the board responsible to receive and open the presented offers, ultimately responsible to propose the ranking of bids plus awarding recommendation in each of the PCP phases. And we were present also in the expert board, responsible of the assessment of the technical offers, and in the monitoring team, monitoring of contract execution in all PCP phases, as well as the assessment of the end of phase report in each of the PCP phases. And I would like to mention some of the overall lessons learned during this process of the project. The first one is that enough time is needed to perform quality research and development services. And except if this is strictly needed, the phases defined duration needs to be respected in order to ensure high quality R&D services and achieve expected impacts. And this was separated in phase 2, not only not reducing its duration, but extending it 8 weeks due to the impact suffered by the contractor due to COVID-19. And in this sense, we have assumed the delays and modified the schedule to ensure the continuity of the project, as we firmly believe in it. And secondly, that public procurement principles should be respected but not feared, and ethics, fair dealing, equity, accountability, and reporting are not incompatible with an effective communication between contractors, lead procurer, and monitoring team. And on the contrary, this is more than necessary in order to obtain an optimum value for money solution. And also, finally, I would like to mention the next steps that ECO is taking to address antimicrobial resistance. As we were telling before, is a problem that we need to tackle urgently, and that's why we continue trusting in the potential of this kind of projects that encourage innovation. And the results and the great contribution to the state of the art that ANTI-SUPERBUGS has supposed, we want to take off the return of this pre-commercial procurement to continue betting on innovation and making a real purchase for hospitals. That's why we have recently embarked on a public procurement of innovation project, which is RADAR, and which seeks the rapid detection and control system for antimicrobial resistance. And so, of course, it starts from the advances that have been made in the ANTI-SUPERBUGS projects. And therefore, at ECO and BINCAT, we remain committed to the fight against the antibiotic resistance. And we are very grateful to all of you for the contribution you have made to the ANTI-SUPERBUGS projects, and also to the EU. We are grateful to the European Union for the trust and support, and which is essential for advancing in this fight. So thank you very much for your attention.
Thank you very much, Anna, for sharing the perspectives from ECO and BINCAT. So now it's time to move to Provincia Autonoma di Trento. We have Emanuele Torri, Francesco Tesarolo, and Sebastiano Ricciardo. So the floor is yours.
Hello. Good morning to everybody, and thank you for the invitation and all the excellent presentations you have done so far. On behalf of Autonomous Province of Trento, we are pleased to share with you in about 10 minutes a free voice presentation, and we will discuss about some elements related to some insights on what we learned. I will start with my part as a public health physician and policymaker of a Department of Health and Social Policy of Autonomous Province of Trento. A few words about our system. We are an autonomous region of about 540,000 inhabitants in northeastern Italy. We enjoy a large degree of administrative
Sorry, Manuel.
in charge for delivering healthcare is the Healthcare Trust of Autonomous Province of Trento, which is the instrumental entity of the province in charge for the delivery. Can you hear me? Can you hear me?
Yes, we can hear you, but it's true that we lost your presentation and your screen sharing.
Do you see the slide now about the system?
No.
Okay.
I can share these slides. Try it, and in case you have any issue, I can share it for you.
Okay. Can I continue? Okay.
A second.
Okay.
Yes. Yeah, perfect. Yes. Thank you, Manuel.
Thank you. And in our province, for a long time, we pursued a smart innovation strategy centered around the collaboration between the provincial government, healthcare services, academia, and research institutions, and particularly the Bruno Kessler Foundation. In ANTI-SUPERBUG project, we brought our expertise in European projects in IMR, including also some previous experiences in PCP and particularly in managing as lead project to improve management of bipolar disorders. We have a very strong priority to combat IPC and IMR, also implementing innovative technology. And an ongoing challenge for us is the adoption of new technologies based on value-based procedures. We had a role in all the work packages of the project, and particularly related to WP2 in analyzing clinical requirements and sharing knowledge and expectations with experts and stakeholders. We supported technical surveillance related to WP3 and the address of medical needs in WP4. Concerning contract implementation and execution in WP5, we site operations either in clinical and during the clinical part of the study. We supported evaluation of the different phases of a PCP, and we were leader of a WP7 concerning communication and dissemination activities, managing the website and creating and submitting also some scientific papers to national and international conferences. Now I hand over to Sebastiano Rissardo, who was the principal investigator of a clinical study that we performed in Trento.
Thank you, Emanuele. Thanks to everybody. I'm Sebastiano Rissardo. I'm an infectious disease specialist at the Rovereto Hospital and the principal investigator for the project in our center. I'm going to take just a few minutes to talk about the epidemiological context regarding multi-drug resistant organisms in the hospital of Rovereto. We have an antimicrobial resistant problem for many MDRO, including those that was targeted in the ANTI-SUPERBUGS project, despite the fact that the situation is not as dire as in other larger Italian hospitals. In this slide, I've included an abstract from the latest report on antimicrobial resistant surveillance in the hospital of the Trained Healthcare project, of the Trained Healthcare Trust, which depicts some antibiotic sensitivity patterns in the Rovereto Hospital. We can say, based on this data, that for Klebsiella pneumoniae, there is a prevalence of resistance to third-generation cephalosporins close to 35%, due to the spread of SBL and AMC beta-lactamases. We don't have, instead, many problems with carbapenemesis producing Klebsiella pneumoniae strains. And for Staphylococcus aureus, the percentage of methicillin resistance is very low, less than 5%. For Clostridium difficile, which is not covered in this slide, there have been no more than 15 cases per year in recent years, and the trend is absolutely stable. In all hospitals of Trento province, patients that are colonized or infected by MRSA and SBL are placed in contact isolation and in microbiological surveillance. Maybe, I don't know, in Germany and in Spain, this is the norm, but I assure you that in the other regions in Italy, it's unthinkable, it's impossible, because MRSA and SBL are now too widespread at the hospital level. Sorry, Emanuele, you can go to the next slide. Okay, thank you. What can we say about our experience of the ANTI-SUPERBUGS project? First of all, our hospital in Rovereto is an acute general hospital with 200 beds. The project in our hospital had initially to start in two departments, in the high-intensity care medicine and in the infectious disease department. Unfortunately, the fourth wave of the COVID-19 pandemic prevented the start of the project in the infectious disease department, which is still a department for only COVID-positive patients. We could therefore use only one of the two devices, and we recruited to date 21 patients, all in the 2022, all part of the sub-study 3B, and test only with the Sense for Care device. As principal investigator, I can tell you that despite the small number of patients enrolled for the issues that I've now exposed, I have received from many colleagues that were involved in the study an absolutely positive feedback about this experience of the last 3 months. And thanks to everybody, I leave the floor to Francesco.
So, thank you, Sebastiano. So I'm Francesco Tessarolo. I collaborated with the ANTI-SUPERBUG project since the beginning. I'm a researcher at the Department of Industrial Engineering with expertise in medical device technologies and in clinical study design. So next slides, please, Jon. Thank you. So this slide is just to let you know that all of us were really expecting and waiting for this final event that is not actually this presentation, but the final event was for the ANTI-SUPERBUG project, the implementation of the clinical trial at the 3 pilot sites for really testing in the field the technologies. So next slide, please. And in these few slides, I want to briefly summarize some information and some experience that we really collected during the clinical investigation. So for sure, there has been many opportunities among the pilot sites. And for sure, what we found as a major opportunity is the continuous collaborative and coordinated interaction between procurers and suppliers. This was really a matter of fact, and allows all of us to value and take into consideration different expertise. then there was a real opportunity to evaluate and define the quality of the tender and check on the challenging innovation opportunities that could be really adaptable to different contexts and countries. And the process was an iterative process. It was not a single step, but it was something that has proceeded in several actions. And this brought to build health technologies based on really evolving scientific knowledge, not only based on a first state of art, but on a continually scanning and horizon scanning of the state of art and of the available technology in the literature and in the field. So this approach allows also to update continuously the end user demands and really try to incorporate in the technology, in the solution proposed by the suppliers, the priority and the needs specified by the procurers. At the same time, it was a real opportunity to explore new clinical design, new clinical investigation design and implementation plans that has to be really fitted to the PCP time constraints and needs. We also see a system, we also experienced the systematic engagement of multiple stakeholders, and there was opportunity to promote the development on a multi-stage evaluation, as I told before, of new technology in the real world. All these opportunities allows for a real value-based purchasing and informed decision-making at the end of the PCP process. So next slide, please. Next slide, please. Jon, if you can go to the next slide.
I think that is Emanuele handling the slides.
Sorry. Okay. Thank you. Thank you. That's okay. And of course, we experienced also several challenges. Some of them are summarized in these slides. The first, of course, is time. We had to really compress time for clinical investigation within the reasonable time for a PCP project. This was not easy. It is something that can be done in a successful way, as we saw, but it has to take into consideration a lot of strategies and a lot of risk mitigation strategies. There is the challenge of engaging external key actors like ethics committee and national competent authorities that bring some uncertainty, especially into the time of the clinical investigation start. And we have also experienced differences among different European countries in the regulatory framework, especially about medical device and in vitro medical device. And this is mainly due to the fact that we are still in a transition from the medical device to the medical device directly to the medical device regulation, especially for in vitro medical device. And we saw difficulties when we need to really classify according to available classification rules the very new state-of-art technologies, prototypical technologies, because they were very often borderline between in vitro device, medical device, or borderline software. And this creates some difficulties in understanding their position and the correct path for the approval. At the same time, the safety assessment of prototypical system to be used in clinical setting is critical. because they are prototypes, and their correct assessment in the field is crucial for the safety of patients. Then there has been also some challenges also in correctly defining what are the primary outcome indicators. And I want to stress the importance not to focus only on the efficacy, but consider as very much relevant also usability, acceptability, satisfaction, intrusiveness, patient discomfort as very valuable indicator for these new technologies. And then finally, there is the very high PCP ambition. So the idea of the PCP is to really go to very high TRL. But we have to understand that the TRL definition poorly fit with medical device technology development. TRL was developed in a completely different sector. And we have also to understand that, to take into consideration that technology readiness levels is not equivalent to commercial readiness level. That is probably more relevant for PCP. Next slide, please, Emanuele. Yeah, I will wrap up with some recommendation that from our experience, we recommend that the whole consortia and also the stakeholders that wants to engage such challenging PCP should ensure that have a thorough understanding of medical technology prototyping, development, evaluation, and implementation. They should consider to run multiple center studies instead of single multi-center investigation to favor flexibility, and define an extended range of primary and secondary study outcomes. Whenever possible, try to consider parallelization on different clinical study phases, this to really speed up the process. Next slide, please. Okay, these were other useful recommendations like synchronized testing at different technologies within a pilot, to have to reduce time and improve comparability of data, consider a reduction of study population because these studies has to be considered as pilot study because no preliminary data are typically available for very innovative technologies. Differentiate study settings. Clearly identify the reference for technological gold standards that could be also locally defined in order to really keep the added value of differentiating the characteristic of different pilot sites. Take care about multilingual support and set clear requirement about data protection and handling. Next slide, please. This PCP, this picture just sum up the experience of the clinical investigation performed in the framework, how we designed the framework. The framework we designed for performing this the whole clinical studies in 3 pilot sites for 2 suppliers, and it was successful. And please, next slides. And the evidence is that all the studies are currently running successfully, recruiting patients and producing evidence on their effectiveness. Thanks for your time.
Thank you very much, Francesco, Emanuele, Sebastiano. Thanks for this great presentation. So now it's time to Sven Schmidl, Parvis Akmagnesiat from Helios. So the floor is yours.
Okay, I will start. I think first of all, thank you very much for the introduction and the opportunity to present and introduce Helios and our hospital in Wuppertal. My name is Parvis Ahmadnejad. I'm a medical doctor, specialist in laboratory medicine, and I'm the director of the Institute for Medical Laboratory Diagnostics, and I have the chair for laboratory medicine and microbiology at the University of Wittenherdecke. The university hospital is a part of Helios. It's a company that runs numerous hospitals in Spain and Germany. And I'd like to give you some key data about the hospital. It's a maximum care hospital that provides almost all medical services with the exception of transplantation medicine. We have 50,000 inpatient cases per year, 2,500 employees, approximately 1,000 beds that are in this hospital. We have a couple of certified medical centers, and we have interdisciplinary centers. We have 4 institutes here at the university hospital, and the head physicians, we have head physicians of 14 specialist departments that hold a chair or professorship at the University of Wittenherdecke. One of the institutes that I like to mention especially is the Institute for Medical Laboratory Diagnostics. And here the classical microbial analysis, they're carried out during all the studies that we have done. We have in this institute more than 17 employees at 3 locations. We supply 7 other hospitals from Helios. We do clinical chemistry with approximately more than 2.5 million analyses per year. We have approximately more than 700 orders for microbiology per day. We are doing a lot of coronavirus PCRs right now, and we have an NGS core facility here to check for relevant variants. The laboratory itself is accredited according to different DIN ISO norms, and we are at the same time a reference laboratory for infectious diagnostics for the Reference Institute for Bioanalytics. This is one of 2 EQA providers in Germany for EQA's external quality control assessment schemes that are carried out. And of course, we also do committee work and we do research. For instance, we are involved in the ANTI-SUPERBUGS project, as you see. And we carry out daily approximately examinations, more than a couple of thousand examinations for the detection of multi-resistant microbes. Here you can see them, which are the slide shows you the analysis that are performed for different kinds of multi-resistant microbes, which we performed in 2021. And these analyses are carried out, for example, for MRSA, ESBL, by cultural methods or by mass spectrometry on the one hand, and in case of Clostridium, we do this via nucleic acid testing, as you can see here. And in the given context, that means that the laboratory currently performs several thousand examinations, as I said before, for multi-resistant gram-negative or gram-positive microbes per month to ensure them and improve patient safety. This amount of testing is certainly not done randomly, but we follow a clear plan and elaborated hygiene procedures to do this. These workflows partly start with anamnestic questions, the results of which are recorded in so-called screening indication forms and then lead to the request of the examinations. So this is from my part. Sven, please, the floor is yours.
Thanks a lot, Parvis. My name is Sven Schmieder. I'm a senior consultant at the Department of Clinical Pharmacology at our hospital, and I acted as a principal investigator in phase 3 of this project, and I was also the part of the Helios team from the beginning of the project as well. So let's move on to Helios activities. Just a short overview. We were involved in all work packages. For example, we were involved in identifying the pathogens we are interested in. We planned the PCP, and of course we monitored the preclinical and clinical results as well. And yes, of course, we conducted the clinical trial. Since the clinical trial is not only about enrollment of patients, I would like to highlight selection of 3 study tasks. For example, we had to adapt the study protocol, and this was done in collaboration with the other 2 sites and the contractors as well. And we supported the contractors in preparing the documents for the ethics committee and the national competent authority, which is also a lot of work, as you may know. And yeah, so despite the fact that the COVID pandemic is present, we had to establish a study team including lab staff and clinical staff as well. And this was quite a challenge. Let's move on to the clinical study we conducted at Helios. As already, it was already said that only the Sense for Care solution was evaluated in our hospital. We were able to enroll the 2 patients on most of the working days, and that's why we ended with 79 patients, which is a quite huge number despite the COVID-19 issues. And of course, these are mainly phase B patients, as it was already mentioned. What are the lessons learned from the clinical study? I think it's really important to have a good collaboration between the medical and the lab team, and also between the sites, the contractors, and the coordinators. And in theory, one could discuss whether the presence of more devices would enable us to recruit more patients. Yeah, but of course, this was a pilot study, and only a limited number of prototypes are available. And the medical staff is really exhausted, I think, in all 3 sites. And this is an original statement which was made by one of the staff members. Why are you conducting a clinical trial right now? And I think this clarifies the issue of the workload. Really good. What are the lessons learned from the PCP? I think Francesco already mentioned a lot of things, just some. Maybe in addition, I think it's really important to avoid an underestimation of the formal aspects that was already mentioned regarding the medical device regulation, because there's an issue with the classification of the devices between the countries. There are some differences which maybe hamper the study. And one could discuss also maybe an early inclusion of experts for these formal aspects as well. And of course, for these formal aspects, for getting an assessment by the ethics committee and the competent national authority, there must be some time, because of course there could be some feedback from the ethics committee which you have to answer and so on. And that's why you need really a realistic timelines for a clinical study. What is also important is a close collaboration between all the PCP members. I think this has been the case in this project, and an early recognition of the upcoming problem as well, and an excellent project coordination, which was really the case in this project. And at the last slide, I would like to thank you for your attention. The others, the pilot sites, the contractors, and the external experts, and the project coordination, and of course, Helios for supporting the project, and the European Union as well. And these are the members of the Helios team. Thank you very much.
Thank you very much, Sven and Parvis, for this great presentation. Indeed, it's been a great pleasure having you on board, working as a pilot site, as a buyer, so thank you. The same, of course, with the rest of buyers. So now let's move on to the last procurement organization, also working as a pilot site. So Hospital Mutua Terrassa, Laura Buña, Josep Ternado.
Hello, morning. Thank you for the opportunity to taking part in this project. Okay, we'll go ahead with our presentation. We present our institution. Mutua Terrassa is a teaching hospital with more than 400 beds, with 34 medical specialties, including medical specialties and surgical specialties. We are also interconnected with 9 primary care centers in their surroundings. We share the same electronic health report, and at this moment, our ICU have 20 beds, and we also have another unit, an intermediate unit, with 21 beds, additional beds. In some moments of this pandemic, we expand this unit to 30 beds. In 2020, more than 1,700 patients were attended in a unit. From these, more than 700 in the ICU. Our organization is organized in 5 service units and employs more than 3,900 people. And we also have Mutua Terrassa Research Foundation that fosters research and innovation projects and services in our institution. At this moment, we also are participating in another Horizon 2020 PPI, Ritmo Core. For this reason, we also enrolled in this project. What was the reason for enrolling ANTI-SUPERBUGS? For the main reason is that the control of nosocomial infection is one of the highest priority. This project was coordinated by the ICU in conjunction with the Research Foundation. At this moment, our standard of care is to perform a standard microbiological test for all patients admitted to ICU in order to detect multi-drug resistant organisms, but unfortunately, these tests take at least 24 hours and in some occasions more than 48 to obtain a result. If this test was positive, we isolate this patient, take contact precautions measures, and adapt treat this infection if we consider that this microorganism is the reason is an infection situation. These multi-drug resistant organisms cause higher mortality, higher length of stay, and obviously, as a consequence, an increase of the cost.
Hello, my name is Laura Bugunyà, and I'm the Innovation Coordinator in Mutua Terrassa. And I will explain briefly the activities that we have been performing in this project. We participate as buyer, a medium-sized buyer, not as big as Italy and Helios, and the VinCats network in this PCP challenge. And so we participated also actively in the needs assessment, the functional requirements, as Afwas was explaining at the beginning of the event. And we also integrated these needs into the Catalan territorial antibiotic resistance stewardship program, which is the VinCat. And we try to liaise closely with them so that we make sure that the result is also consistent with the territorial activities. Then the procurement was launched, And so we participated in informing companies that we were aware of that this challenge is open for proposals for bids. And during the procurement, we split the tasks. Dr. Trenado was member of the expert board, and I have been member of the monitoring team. And we are also, we've been, as was already explained, one of the 3 pilot sites, specifically in our ICU and semi-ICU wards. Then in October 2021, our ethical committee approved both studies. And since, as already was explained before by other speakers, there were some problems with the regulatory authorities in the other countries. Since in Spain, they gave us the authorization to start this observational study with this solution, this medical device, we could perform parallel testing of both solutions versus the gold standard. And here in this picture, we can see how the MVOC device, which is from one of the companies, as was shown before, a patient is breathing into the nozzle of the device, and a breath analysis is being performed.
Okay, during the study period, we recruited 52 patients for both solutions, mainly in phase 3B, in the screening performance, and start in parallel both technical, analytical, and diagnostic screening. One of the surprises of this period that despite the solutions are not harmful and hardly invasive, not all patients agreed to participate. Some reasons were perhaps the clinical situation with pain, or the immediately admitted to the unit, perhaps are not the best. Patients said that I am not in my best moment. Perhaps they not detect their individual and immediate benefit from their participation. And some of them also see the swab samples are an invasive proof. So another, for this reason, not all patients get the approval. Another issue during this period was the COVID-19 pandemic affect our capacities. We have a lot of patients admitted to our unit due to COVID, and this have a negative impact on our recruitment capacity and the testing activities for this protocol. Our experience, where we have no direct access to the results because medical staff was blinded to the techniques in a study, but and these activities was done by the sponsors. But in this time, we have access to the result of the standard tests, gold standard tests, swabs, environmental sampling. And when we talk with our patients, we appreciate that the high satisfaction with this technique. Our impression is that we have to, in the future, we have the limit of detection for each pathogen. We need to define the distance from the patient, perhaps incorporate some machine learning algorithms in order to improve. And we are also sure that it's a more rapid detection of these classifications have a great big impact in the clinical clinical theater. So we think that we should further exploit via these techniques via PPI or other instruments. What lessons learned from this period? It was very difficult to run two solutions in parallel in a very short period of time, and also in a setting with a sixth wave of COVID-19 pandemic ongoing. We have also some technological pitfalls of the tested solutions. We need to dedicate some time to solve these pitfalls. And this have an impact of the opportunity to improve recruitment. And another problem was in order to improve recruitment, we submit another version of the study protocol to our ethical committee to obtain a delegate consent from the families in order to include more ICU patients, because more of them are sedated. And this is it was we don't obtain this approval until the last week of the period of study. Another problem was the COVID pandemic restrictions with restrictions in family visits. So this is another problem in order for the study. Thank you very much, and I want to thank especially to Laura her dedication and implication in this study.
Thank you very much, Josep, and thank you very much, Laura, for this great presentation and sharing your views. Really interesting. So now let's move on with the perspectives of the supporting entities role. It's true that we are a little bit behind the schedule, but we will try to reduce some of the scopes from the next presentations in order to get on time to the perspectives of the keynote speakers. So this being said, I leave the floor to Sarah Bedin.
Thank you, Jon. So I will be very short. Thanks for this experience we shared. A few considerations about the lessons learned. I get the confirmation that PCP offered to public procurers the opportunity at early stages to steer the solutions development and to adapt this to their needs, avoiding to develop unnecessary features and addressing the work of the companies. So I get a confirmation that PCP is a powerful instrument to address research avoiding lock-in. This has been, in my opinion, fully confirmed in this PCP project and the Superbug project. The other consideration is that the unbundling procurement, which separate the pre-commercial phase from the commercial rollout, is the most effective way to proceed. I think that based on the experience, it would not be possible, have been possible to commit for the buyers to purchase the solution beforehand. So the demonstration that the separation between ANTI-SUPERBUGS and rather project works effectively is another confirmation on how is powerful this instrument. Another consideration concerning the real concrete level of standardization interoperability that can be achieved, I have to say that I noted how this is complex, starting from early technology readiness level, and because all hospitals have some specificity, and what is the experience I get is that the authorization processes at national levels are really significantly different and takes different times. Just to make an example, in Spain it takes 1.5 months, and in Italy 6 months has not been enough to obtain the authorization. I think that in this area, a fast track for authorization at the European level of clinical trial would be extremely important, especially for medical devices, has been already said. The final consideration from my side is that the joint and cross-border procurement that we adopted and delegated procurement is, my opinion, the most effective approach to manage a project of such complexity. And I think that it forced us to think Europe rather than local, but and of course it created the chance for companies to get internationalized and start internationalization. We have here two winners, two awardees that have created a growth based also on the participation of PCP. So we have also important and successful stories from SMEs that has grown thanks to these PCP initiatives. I think that the Horizon 2020 and now Horizon Europe framework provide a great help because it provide a strong joint cross-border architecture. Otherwise, without this framework and tools and support from European Commission would have been extremely complex to implement inter-administrative cooperation that would require an international public-public institutional relationship that can raise issue of international public law and administrative law. And I think that the European funds and also process in monitoring the projects is of great help. So I think that to implement a PCP, starting and learning within a European funded project is extremely informative, really helping and really supportive. So thank you very much.
Thank you very much, Sarah, for sharing your views on the utility of the overall PCP tool. Yeah, thank you. So now it's time for Ulla Elofsson from the Research Institute of Sweden, RISE.
Many buttons to press. Yes, so thank you, John. There we go. So I represent one of the supporting entities in ANTI-SUPERBUGS, RISE, Research Institutes of Sweden. It's a national institute that was merged from around 30 different small institutes during the last 10 years. And we're altogether about 2,800 employees for the moment. We are involved in many different EU projects, and we have a special mission to support small and medium-sized enterprises. We are a polytechnical institute, as we are a merger, and two of our focus areas are digitalization and health and life science. In ANTI-SUPERBUGS, we've been responsible for leading work package 3 around the state-of-the-art analysis, and with particularly working with the state-of-the-art analysis and the technical surveillance during the project. And some of the learnings that we've done is that it's difficult when the project time is such long, and this is, as pointed out several times, partly due to the pandemic. But as a supporting entity, it's good to have some extra funds in that case. I will also like to point out that it's good to involve the technical expertise in the process when defining the challenge brief, because this will save time when establishing the state-of-the-art report. Finally, I think it's really good to say that it was a highly ambitious challenge brief of the ANTI-SUPERBUGS that really pushed the boundaries for the PCP solution, and that is shown by that it's still valid 2 years after the signature, or more than 2 years after the signature of the first PCP contract in phase 1. So thank you very much.
Thank you very much, Ulla. I think it was my case, but I couldn't see the slides moving, but in any case, you presented it perfectly, so thank you. Yeah. Thanks very much. So now let's move on to the next step, where Maria Sanchez from Aquas will present Radar PPI and how this project will continue fighting and contributing to tackle the antimicrobial resistance issue. So Maria, whenever you want.
Hello, can you hear me now?
Yeah, no, we can hear you.
Okay, sorry that I was mute. Can you see my screen?
Yeah, yes? Perfectly.
Okay, so I will present today the Radar project. As is been mentioned already, is the public procurement of innovative solutions for rapid detection and control systems for antimicrobial resistance, and is kind of a continuation on this ANTI-SUPERBUGS project. So here are the entities participating, and I will show you and introduce the project, objectives, the innovation framework and the plan, and the consortium partners. The Radar project only started in the 1st of January 2022. And our objectives are the procurement of innovative solutions according to buyers' needs that can lead to a rapid detection and diagnosis of pathogens and antimicrobial resistance that limit their spread, adoption of a cross-border effective control and prevention system of infection by a communication system based on epidemiological statistical data to be developed locally, accelerate the scalability and replicability of the adoptive innovative solutions in healthcare organizations, and promote SMEs to access to public tenders with their new solutions. So in that sense, you could see how we have identified the vehicle we want to use and some of the needs that could be addressed through this PCP. This PPI, that this doesn't mean that all of them needs to be addressed, but they are included in our perspective, because we are now in the needs identification part. And we have also discovered some relevant stakeholders that we want to engage with. That is the healthcare organization and central purchasing bodies that are including the buyers group and also, of course, SMEs. Additionally, we want to strengthen and increase the resilience of the health system by improving the health outcomes and the digitalization of the information, improve the treatment effectiveness, reducing the time of care, and also the prolonged length of stay of patients that cause governmental cost and operational impact. So in that sense, we want to contribute to the reduction of nosocomial infection incidents, and also to develop new reimbursement models with the payers. based on the adopt innovation solution in antimicrobial resistance. And again, we already identified some of the expected outcomes we want to cover with this PPI, and also the long-term sustainability of the innovation adoption. So how we want to do it and how is our innovation framework is we start with this clinical demand definition I already mentioned, with all the buyers and different experts, scientific experts in the consortium, with this common needs identification, and also these needs will be verified through the reference business cases and stakeholder engagement. In that sense, we want to feed this clinical demand definition will allow us to ask the market in our market readiness assessment dedicated tasks. So we will analyze the state of the art and the market research, and we will do some market sounding and open market consultations that will allow us to, in an iterative process, to feed back again this clinical demand definition. So this circle, we will do it several times along the first part of the project. Once we have clear that what we need and is clear and the market is ready, and the market could answer our demand, we have identified the public procurement of innovation as the vehicle for satisfying these needs. And the way we want to do the procurement is a value-based collaborative procurement. So we will do the definition and coordination, and then a coordinated contract execution and monitoring. That also will feed one to the other. So this is the work packages, how it's divided, work package 1, 3, 4. And then in work package 5 and 6, we will do the coordination. So our project plan is kicking off the 1st of January 2020. We have done already an early print publication to be able to connect with the market and start scouting. And we are planning on performing the clinical demand definition and market readiness assessment until the end of the first quarter of 2023. Then we will start the tender preparation before and also opening a second prior information notice that allow us to start or kick off the open market consultation events. So finally, we are planning on month 23, like at the end of the 2023, to present and open the tender. So we will accept the offers and we will do the awarding between month 23 and 27. So in the beginning of 2024, and the contract execution will take place during 2024 and 2025. In that sense, what we want to include and incorporate is the monitoring and evaluation of the contract, as we have done in ANTI-SUPERBUGS, and it's already explained, having interim evaluation reports before the final evaluation, because it's been really helpful. And we want to include this change management time of 6 months for the adopted innovation to adapt and change to the different buyers. So the clinical demand definition will be based on the problems that we have already during this session highlight, that is the multi-drug resistant organism is increasing, that is causing a lot of death and is a high economic burden. So our needs to respond to the EU jump rate that is being explained action plan. So we want to improve early detection system to ensure quality care process, to improve effective treatment, to increase system resilience by reporting and communicating fast, and to reduce the healthcare and governmental costs. And this will strengthen the health system, ensuring the preparedness and resilience that has been shown by COVID-19, that has focused the importance on an effective infection detection and control system to control the spread of infections. So we will do a value-based cross-border collaborative procurement. So we have 4 buyers that will go through a common preparatory phase and clinical demand definition and a common and local market readiness assessment. But we will do an individual tendering per locality. So we will have 4 different tenders, and then 4 different contracts will be executed in a coordinated way. So as we have explained, this will cover work packets 1 and 2 and 3 and 4. That will be all coordinated. Our partners are composed in the consortium of 4 buyers. That is RESA, that is a central purchasing body in France, Osakidecha, that is the Basque Country in Spain, Unina DISAP, that is the Department of Public Health from the University Federico II in Naples, Italy, and ICO, that is also partner of ANTI-SUPERBUGS, that is the Institute of Oncology here in Catalonia. And as supporting entities, AQUAS, we will be the coordinators of the project. We will have INSERM that already participate in this event from France, and we have INSME in Italy that will be devoted to communication and dissemination strategy and engagement with the SMEs. That is an international network of SMEs. JERA from the UK, that are a procurement consultancy company experts in procurement and especially in public procurement of innovation, and Biodonostia Institute of Health and Research that will also support together with INSERM with their expertise in antimicrobial resistance and detection systems. So our expertise covers clinical and scientific experts in antimicrobial resistance, public health and hospital-acquired infection, public procurement of innovation, PCP and PPI, demand-driven innovation experts, and market assessment and engagement experts. And these are all the different initiatives that different partners from the consortium has been involved. ANTI-SUPERBUGS, JAMRAY, different associations as EPA and value-based procurement, the PINCAT, nosocomial infection program for Catalonia, EcoQuip, Eurifi, TICE, OncoNGS, and PPI, the platform for innovation procurement and procurement of innovation. And thank you. Oh, keep connected. I would like to take the opportunity to show you the webpage, link, and Twitter. So if you get your mobile close to the screen, you could connect with our LinkedIn and Twitter account. And thank you very much for your attention.
Okay, thank you, Maria. Now we go to the next session. Unfortunately, we are some minutes late. So let's try to now recover the time in the few minutes that are left. I'm trying to see if I can share my presentation. Hopefully you can see it in presentation mode. Now we are going to have like 3 blocks in these last sessions. We are going to have a presentation of how we evaluated and we monitored the overall project and the offers and the contracts. Then there will be a short presentation on setting the scene on how the evaluation really can impact on the designing PCP and PPI in healthcare. And then we have some perspective from keynote speaker, Carmela Plazas, that is the Deputy Head of Unit Innovative and Personalized Medicine European Commission, DG Research, Mark van den Burg, Head of Services in Sensano Cancer Center and coordinator from CONGES PCP, and Yves Verboven, director of EU for Health Solutions. And then we will have a round table. In the program, there was also invited and confirmed Liv Bosset. Unfortunately, at the last minute, she could not join. So with no further delay, let's move on. And I will ask Jon and Maria to shorten their presentation and not be so extensive. Thank you very much. I will stop sharing. I don't know how to do it. Okay.
Thank you very much, Rosanna. So we will try to speed up, not going too rush. So hope you can see the screen. I would take that as a yes.
Yes,
so,
yes.
Okay, thank you, Rosanna. So let's see how and to what extent it was relevant for us to include an evaluation work package in ANTI-SUPERBUGS PCP project. So in this case, the objectives of this work package was to first design a framework for the evaluation of the received bids, of course. Secondly, to generate for each of the phase of the PCP an evaluation standard report aimed to present and to show the evaluation related activities conducted and results obtained for each of these phases. And of course, ultimately to show what's the outcomes and the impact that has been achieved through the overall initiative. So we also performed different assessment at the end of phase 0 and then at the end of phase 3, once the PCP was completed. So when drafting or we're completing an evaluation framework, in our case, in the ANTI-SUPERBUGS PCP, we had two main objectives. The first one, to evaluate, to be capable of evaluate the overall PCP initiative and the project itself. And secondly, to properly assess and evaluate the bids and the execution of the contracts awarded in the PCP, always in agreement with the public procurement principles. So to fulfill the first objective, we designed through mixed methods, both with qualitative and quantitative analysis, 30 different indicators, which were divided in 6 categories, also taking into account European Commission recommendations, literature review. So we designed and we defined 30 different indicators divided in these 6 categories, related with the project management, related with the object of the contract, to what extent we have promoted the PCP among the industry players, as we have seen among 18 economic operators, to what extent the procurers and the bidders were engaged, and mutual learning was fostered among all the partners. So again, this assessment was performed at the end of each of the phases, including at the end of phase 0. To fulfill these second objectives and to be capable to assess and evaluate properly the bids and the execution of the contracts, we defined different boards. First, to evaluate the bids, we composed and defined a tendering board composed always by representatives by the buyers group, as well as expert board who were the ones responsible to assess the technical offers of each of the bids. Secondly, we had the monitoring team who was again represented by the buyers group as well as independent experts in order to assess and monitor the contract execution at each of the phases. So when was this performed? In the intermediate of each of the phases and at the end of each of these phases. So as a summary of the evaluation framework, we had the assessment of the PCP initiative at the end of phase 0, phase 1, phase 2, and phase 3, and the proper evaluation of the bids and execution of the contracts during and at the end, phase 1, phase 2, and phase 3. So now, but just as some outcomes regarding the end of phase 0 of the activities undertaken in phase 0, a pan-European network of procurement organizations was consolidated and well committed to co-invest the 30% of a very relevant amount of money in the field of antimicrobial resistance. Mutual learning and knowledge transfer was fostered, and they were involved along the whole procedure, not just with internal, but also with external stakeholders. The resulting common challenge defined aimed to revolutionize the current state of the art. And as a good result, the companies confirmed the existence of a high potential in this new EU market related to the health-acquired infections, as approximately, counting with the market consultation and the call for tender, it was more or less 40 companies that were approached during the whole preparation phase. So now I will hand over to Maria.
Thank you, John. So during the evaluation of the bids, as John was saying, we create this representative group of the buyers, and also we count with independent experts. So even though it was an individual assessment of each of the offers, we could have an expert board where we can assess different technical parts and contribute to this awarding of the submitted tender. They, of course, use the mechanism of the awarding criteria described in the different annexes of the request for tender. So the methodology for the monitoring of the contracts used was also creating a monitoring team composed of different buyers, representatives, and also independent experts in the field, so they could monitor and assess the contract implementation at each of the phases. In that sense, this will ensure the correct achievement and the expected outcomes. How we did that, it was during the execution of the phase, we had an interim outcome report that it was assessed by the monitoring team, and in that way, we could have a continuous contact, give recommendation to ensure the achievement of the objectives before the end of phase report and the final assessment. So we had an intermediate point. The evaluation of the contracts were done by this monitoring team, and it covers two aspects: the satisfactory completion and the successful. In the satisfactory completion, we were assessing that the work was carried out, that there is a reasonable quality of the reports and the demonstration that it was everything was submitted on time, that it was a proper allocation of the money and compliance with the fair framework agreement, and we could pay for the execution of this phase. While with the successful completion of the contract, we were assessing that the milestones were successfully completed, the research and development results met the performance requirements from the challenge brief, and the results are considered promising, and we could give feedback on the implementation. In that sense, if a successful if the completion of the implementation of the contract was successful, we could invite them to the next phase. So our communication channels were extensive. So we had different files and mails with doubts and with documents. We also had meetings in Teams, and also we had a repository on Nextcloud for the contracts. So in phase one, that it was the solution design, the duration was 10 weeks and starting on March 17, and we wanted to complete the interim solution and design the lab, the validation of the prototype in the lab environment, and both fourth contractors, were assessed satisfactory and successful by the monitoring team, ensuring the competitiveness also of the PCP, and they were invited to phase 2. The overall results of the methodology were to ensure the adjustment on the implementation of the contract, the scope, objective, the mutual collaboration and learning, as it was said during the presentation, this risk management plan, we could adjust, we had time to react, and we create a space and a way to give recommendation and adaptation to the context. So we also create a clear evaluation methodologies for the satisfactory and successful that helps with the transparency, equal treatment, and objectivity of the final assessment of the contract implementation at each phase. So as the main outcomes of this evaluation is we could say that we had 4 technological approach or solutions design. We could give them 303 recommendations, 76 for each partner. So in the prototyping phase, we also assess satisfactory and successful each of the 3 of the contractors. It lasts 20 weeks. We had to extend it 8 for COVID. And all the different milestones were completed. So we had the research protocol, the data management plan, and the solutions ready for testing the prototypes. And all the 3 were satisfactory and successful. So the main outcomes were similar to the others. We had fluid communication and efficient implementation of the contract. And for phase 3, the duration was 34 weeks, and they also got a satisfactory but partially successful completion of phase 3. But regarding the outcomes, we consider we have a scale or provoke the maturity, technology maturity level of the developed solutions, TRL 6 or 7. So both solutions were considered completely aligned with the needs and formally agreed to continue the activities in the different pilot sites, to get to the contract termination and the further results achievement. And this is it for my side.
Thank you very much, Maria. Thank you. So regarding the overall PCP outcomes, we can say that ANTI-SUPERBUGS has contributed to give response to the current problematic of antimicrobial resistance. Overall, with the feedback of all parts in each of the phases, we can also consider that mutual learning and knowledge sharing has been fostered, and now I think that all of us have gained a lot of experience in European Public Procurement Directive, in the treating principles, and in the public procurement principles. We have opened definitely a route to the market for new market players, as 9 SMEs and 3 research centers have signed at least 1 contract with us and ANTI-SUPERBUGS PCP. And also a very good news is the 100% of the contracts performed the 100% of the R&D in Europe, contributing to the growth and jobs creation. Additional project outcomes that we can highlight is that we have increased, as we have also presented at the beginning of the event, the impact of public procurement, in particular of the pre-commercial procurement, as a very interesting tool to foster innovation in fields of public interest. We have increased as well the awareness in the healthcare and scientific community with regards with the project outcomes, where we are presenting in main national and international congresses of antimicrobial resistance. And again, achieved results we will ensure that there will be a continuity in tackling the antimicrobial resistance field with the RADAR PPI project. Just to conclude and to share some of our lessons learned as lead procurer, given that we have also gathered the ones from the contractors and from the buyers group, we want to also share some lessons learned from our perspective. In order to be, for those that are encouraged to perform an activity as a lead procurer, we want to highlight that the organization's commitment is vital. We had it in Aquas and it was just vital. And here there are some stakeholders that we needed to engage and to have continuously engaged, as this is the contracting office, the financial officers. We also needed some legal expertise, and for those that might not have this legal expertise in their organization, don't hesitate to look it outside and subcontract this. Project managers are also very important, as we are acting as somehow as an orchestra directors, trying to engage with all the different partners internally and externally. And acting on behalf of the buyers group means that you need to engage continuously with all the buyers group representatives, the members, because we are at the end of the day using their funds and their financing. So we needed to make sure that they are happy with everything that is taking place during the innovation procurement. To do so, we need ongoing communication and transparency at all terms. And don't be afraid of the public procurement principles. These should be respected, but not feared, as they can be used in order to better engage with the different parts and also with the contractors. It really takes time to act as a lead procurer and effort, as continuous evaluation is needed, related with the risk management, as Maria was mentioning, and also the different monitoring of all the activities. Despite all these facts, we can say that after all, it's a very key and great, incredible privilege, an immense learning experience, as we have been able to interact from the very beginning, from the unmanned scientification, and act as the first observer and participate along the process. So engaging with all the partners, it has just been amazing. So thank to all the parts. I think that this is all from our side. Thanks very much. I'll hand over to Rosanna.
Thank you, Jon, and thank you, Maria, for this nice presentation. I will now share my screen again. Okay, 1 second. Okay. I would like to ask you at least nodding your head if you see it in presentation mode. So at least, okay, thank you. So regarding the evaluation, why for us is important? Well, first of all, because we are an evaluation organization. We are
Sorry,
an evaluation.
Rosanna,
Yes.
we are not seeing it at the presentation mode, at least not myself.
Okay, thank you. Thank you for telling me. So let's see if I do it again. And
We saw the presentation, but not in presentation mode.
Okay, good. Thank you. So presentation. Now, is it correct?
Yeah, perfect.
Okay, thank you very much. We are Aquas is an evaluation agency, no? And we are an innovation area supporting the Department of Health, the entities, the health providers from the Department of Health to take a decision on when investing or not, and taking the risk or not to engage in procurement activity of research and development and innovation. And so because of this, for us, really, evaluation is a key part and a key aspect of this kind of projects and this kind of initiatives. So at the end of the day, we believe that there are different aspects, no, to evaluate across this kind of initiative: the project, the action itself, the procurement procedure, how we are doing across the different phases, because the PCP is a special complex procurement procedure, and also what Maria and Jon presented, also the evaluation of the project, but also the project objectives, the achievement of the project objectives, but also how we evaluate the offers, how we evaluate the bids, and how we monitor the contract. The research and development in general is this activity that we are doing in the research and development is going to really meet the initial objective that were defined. And then there is a more, but very important aspect, that is this preclinical and clinical study that take place take into consideration the overall innovation adoption from the R&D up to then finally we adopt it in the health system. It's true that the preclinical and clinical study are matching with the phase 3, at least maybe the preclinical, but the clinical maybe not. Why? It is possible, is not possible. And so at the end of the day, if we want to start this kind of, we have this vision to address unmet needs, to do R&D, and then to come up with the clinical, clinical study that gives us evidence and then support the adoption. This is the journey we need to do, and this is the part that somehow are the ABC, are the basics elements to design the overall project, the overall procedure. So we need really to find out, when we start to define the beginning, we need to think to the end, because if not, we are losing some pieces in the middle. And there are different ways, different levels of this evaluation. Clearly, I'm now starting with innovation transformation of the system. It is our area, our program. Now we are running from Catalonia. That how then this will support us in this adoption, but clearly there is a policymaker, the European Commission, that is defining this kind of program. One of the buyers, that can be one of the buyers we had today from ANTI-SUPERBUGS, or one other buyer that we invited today, that is Mark van der Bulke, and the industry representative also, how the industry is seeing all this process. So in ANTI-SUPERBUGS, we define our unmet needs. And to define our needs, we went through a different process of verification. These needs were really first of all, needs not addressed from the market, but also from different processes that can be in place. Maybe it's not just a matter of technology. Maybe it's a matter of how the healthcare providers are working, are putting in place their protocols, and so that's important to verify the unmet needs are real unmet needs. That the market, assess the market maturity to address these unmet needs, assess the business case. The business case was mentioned by Jon, is really a relevant exercise, because it's not just, I would add something more. Jon said it justifies the rationale of addressing these unmet needs, but also it justifies that somehow it identifies the elements that where we will continue to suffer a pain if we don't address these unmet needs. That is, somehow it offers the opportunity we identifies what is the missed opportunity if we don't do nothing in front of these unmet needs. And then clearly, so state of the art, market consultation, and then depending of where the market is ready, we go through a pre-commercial procurement, R&D agreements, public procurement of innovation, or no public procurement. In the case of ANTI-SUPERBUGS, we identified that at the end of the day, we have all the protocols we put in place, and also this was already identified by the buyers in the previous sessions. Unfortunately, we can have uncontrolled transmission of multi-drug resistance in the healthcare facilities. And this causes increase of morbidity, mortality, increase of hospitalization cost, adversely affecting patient experience. And in this analysis, now we identified that maybe the treatment of patient can greatly complicate the clinical practice. We have additional cost and poorer outcomes for the patients, extended length of stay, ongoing cost, in the routine monitoring of the antimicrobial resistance in patient environment, and also in effectively decontaminating the near patient environment can clearly increase, or with a solution like ANTI-SUPERBUGS in part can maybe be reduced or run in parallel. We'll have lost income resulting if it is necessary to close hospital wards and ICU units, and also colonized patients are relevant to be identified because can result in prolonged length of stay, since 1/3 of all colonized patients can then get infected. So also we determined again this opportunity loss. So if we don't do anything, this is what is going to happen. We are going to have more than 40 million loss in Catalonia. We have 11 million loss in Helios, and also in part we have losses. So at the end, this was clear that it's the moment to act now, and also with a vision again of what is the future. And also this was also shared with the industry. So the industry knew that this is a R&D phase, then we need to go to product, and then we have the commercialization phase. And what happens, what are the requirements from the buyer's perspective to move on? In the R&D phase, we had this risk benefit sharing agreements. So we were using this two-steps approach that I really want to thanks Sarah with her conclusion, because I share with her that in case of a solo TRL, like ANTI-SUPERBUGS, where we were somehow disrupting, we are creating a completely new way to act and to intervene in healthcare service provision. A two-step approach is most probably the way to go, because we really didn't know then at the end how we were going to progress with this experience, because this really was we started with a low level of TRL, and maybe in other experience, maybe a two-step approach is not necessary. So, but by the way, in ANTI-SUPERBUGS, clearly I agree with her. It was a relevant way to go. We identified the long-term impact indicators, like the overall prevalence of nosocomial infections, so reducing of the prevalence of nosocomial infection related to the target microorganism in ANTI-SUPERBUGS, also the reduction of reproductive rate of infection, mortality rate due to healthcare associated infection. And so if we see it like in the theory of change, that we can, in the theory of change, because of an intervention and because you have initial inputs, you develop activity and you have some results out of it that can be considered outputs, outcome, impact. The outputs are clearly something that we can measure in the PCP, and we had the opportunity to measure in ANTI-SUPERBUGS. But the outcomes, what happens with the outcomes or the impact? Can we really say that we created a reduction of the overall prevalence of nosocomial infection? Can we really say that we impacted the mortality rate or the cost in terms of routine monitoring? Or can also we say that we impacted the length of stay, or the MDRO colonized patients in clinical outcomes, MDRO infected patients clinical outcomes? So we are still far from it. And so somehow, again, the design of going towards addressing our initial unmet needs is still has a journey to do. And this is somehow the conclusion, that is the evaluation of all these steps doesn't mean that then with the PCP, you are ready then to go directly with a commercialized solution. And so I would like also to somehow put this picture on the table, where we can see that clearly we can have R&D agreements, preclinical and clinical investigation between R&D individual healthcare providers or a group of healthcare providers and industry, no, to increase the TRL. But at the end, when we decide to go to the healthcare system and we want to go to a public procurement, maybe we need to have some evidence that then will support the payer and the health insurers then to cover this new way to do in the health system. So I stop here and I will leave my guest that I can see that already Mark and Eve have switched on the camera. I also would like to ask Carmen to switch on the camera as well. And I will also stop my presentation. I know that Carmen sent to me some slides. So Carmen, while I will present, I'm going to present your slides. Okay.
So maybe
yes.
While you are displaying the slides, maybe first of all to invite me, but also for all the work done, because I can imagine how difficult it has been to go on with the project in the context that we have lived in the last 2 years. So congratulations already for all the work done. So I will be brief in my introduction, because I think it's more important to discuss in the roundtable and to share different considerations about innovation procurement and about how we can improve it or we can build on it in order to achieve what we want, which is to increase innovation in healthcare. And that's maybe you can go to the next slide, Rosanna. So here in this slide, you can see different reasons for which we support innovation procurement from the Commission perspective. These are in general and not specifically to healthcare, but I think that in the context of healthcare, they are even more reasons in order to further support the use of this instrument, because if you want to embed innovation into healthcare, you need to do it mainly through the public sector, because it is one of the sectors where the public spending is the highest. The average in Europe is around 70%. So if you don't do it, if you don't invest in innovation through the public first, it's going to be very difficult to transform it. So the reasons why, so what we want is also to support this demand-driven innovation, where it's very important in order to ensure that innovation is going to somehow not just be something, a more expensive way to continue doing things in the same way, but really to have the transformation to ensure that you are not just paying more to introduce innovation, but that you have a complete different way of doing things that answers the needs of those who are mainly the main actors in the healthcare field. And that's why I think that one of the main objectives that we are pursuing by funding innovation in healthcare is precisely to help to sustain this dialogue between the demand side and the supply side. This is for us one of the main reasons to continue to support. And it is also one of the main reasons when we talk to the procurers that launch themselves into this adventure, to the providers that do participate. This is one of the main things that and it was said this morning. I mean, the continuous dialogue helps a lot, both the industry side, but also the demand side. Launch yourself in this instrument if you have a need, a concrete need, for which there is not yet a solution to the market. So having the possibility to be engaged in very continuous dialogue with those who can potentially help you to address that need is something that it's a big advantage. Same for providers. If you have the opportunity to be able to accommodate, further develop your innovations in order to ensure that you address the needs of those who will ultimately buy them, for us it is very important. Maybe we can go to the next slide, where you can see that from very different angles we have supported already since FP7, and here what you see is mainly the PCPs that have been launched in the context of 2020, with a few exceptions that were already funded through FP7. So we don't have yet here Horizon Europe, but next slide. And you see we have in plain started in the field of that later there have been some close to less IT maybe and more on the more specific clinical side.
Carmen, sorry to interrupt you. Sometimes you get far from the microphone and we cannot.
Okay, is it better like this?
Yes.
Okay.
Thank you very much.
Sorry for that. So anyway, just to give you a flavor of the different PCPs, pre-commercial procurements that have been funded from the Commission in FP7 and mainly Horizon 2020. And maybe we can move to the next slide where, still to the next, because obviously we will continue our efforts in Horizon Europe. And the first thing that we are going to fund and that we expect will start working before the summer is a coordination and support action, where the main aim that we are looking for is the widening, is to ensure that innovation procurement is used as an instrument in much more regions that is currently is now. So we have seen that there are some very active regions and even member states testing and using and going quite far with the use of this instrument, but in some other places it is really not known at all. So we would like to support the capacity building, the exchange of knowledge, but also to support those actors who are more who have more experience to go through the next stages, and that links to what you were saying, Rosanna, because there are some barriers that need to be tackled, and these barriers go through the how to further support or consider issues like the certification, the validation that are particularly more complicated in the healthcare field. So we are expecting for this coordination and support action, which is a quite big one when we compare to other traditional coordination and support actions that we have funded, to really help both those who want to start and those who are already who have already built an experience. Of course, we will continue to support pre-commercial procurement and public procurement for innovation, and you can move to the next slide, Rosanna, where you see, well, I guess, and I hope that some of you are already aware of these opportunities because the deadline is very close. It's in 3 weeks, I think. So we are going to we are proposing the use of this instrument to support the resilience of healthcare systems, in particular in the context of the pandemic. So it's one of the 2 instruments that are going to be funded also with the support of funds from Next Generation EU. And last, maybe just to remind that you saw you can go to the last slide. So of course, as you saw in slide 2, there are several ongoing pre-commercial procurements. So it would be good that you keep informed on the different call for tenders that are launched. The easiest way to follow is through the innovation procurement newsletter that colleagues from Connect are really very regularly updating, and where a lot of information is found not only on the European innovation procurement instruments, but also regional and national ones. That's also an important element. I forgot to mention on the coordination and support action. Of course, we are supporting European projects in this field, but we are not particularly considering that this is the only way to do it. So as part of the actions that this coordination and support action will have to look at, will also be how to support the use of this instrument also at other levels, because there have been very successful cases at regional level on how to procure through the use of this instrument. And then I just wanted to remind that there are some different frequently asked questions, webinar sessions on how to better prepare yourself for innovation procurement, and to keep engaged with us for the work program 23-24 that will be most likely published only at the end of the year, but where we hope that innovation procurement will also be supported in the context of healthcare. And I want to stop there. Thanks. And of course, we will continue the discussion in the roundtable.
Thank you very much, Carmen. So now Mark, do you want to share the slides by yourself, or do you prefer that I share the slides for you?
Yeah, Rosanna, I think it's safer that you share them, because if I do it afterwards when I go out, I'm out of the meeting. That's my experience with the teams.
Okay, 1 second that I'm going to do it.
Okay, but I can start then. So,
yes.
So thank you very much for inviting me. Maybe I should briefly say to the audience, who is Scienzano? So we are the National Public Health Institute of Belgium. And we are in fact involved in a very broad range of aspects of public health. So we have very many activities in infectious diseases. We were the focal point for data collection in the COVID crisis. We have active groups in the non-communicable diseases with a focus on cancer and rare diseases. We are in animal pathogen monitoring, and we are doing generally surveillance and monitoring of all infectious diseases in Belgium. We are in food safety, in vaccine safety, in medical drug safety, and also in quality assurance of the labs. Now, why would an organization like Scienzano be interested in PCPs? Well, we are often the coordinator of networks in Belgium, and in these networks, there's a lot of devices that are necessary. And there starts to be the thinking on common use of the same devices in the same programs. And from that side, especially in the topic that my group is involved in cancer, there is the need for these complex testing facilities and tools. And for there was the idea that maybe we should get involved in being the lead procurer of networks, or let's say a buyers group on this complex testing. So the next slide, I will focus indeed on the whole exercise, because it's the importance of the healthcare system. And now I take the other hat, because I have two hats. I have the head of the buyer but also in direct support of the payers in Belgium, and actually the cabinet and the government. So in 2016, we launched the initiative on starting to introduce genomics in our routine diagnosis, so really in the healthcare system. And there was a health service evaluation done together with our health technology body. And then we came up with 10 actions that, in fact, guaranteed that the introduction of this technology in our routine diagnostics for oncology would be accessible to all, because that's the basic principle that we have in Belgium. If you introduce innovation, it should be accessible to all. And in the next slide, in fact, the approach, the roadbook that we made is in fact a plan. And by now in 22, we are, I would say, fully operational. So we have made a guidelines to standardize and harmonize what testing could be done. We have a commission that oversees follow-up on innovation and what should be introduced as new indication and testing in the healthcare system. It's running under accreditation, which in Belgium is covered by BELAC. We had to be very creative in funding that, and we coupled for that new drugs that come on the market with direct approval of the testing, and we reallocated money that was assigned to single testing to NGS. So it's a very complex exercise that we made. We also decided that the data should be collected centrally. And so we have this health data structure with a link to the National Cancer Register. We had a vast debate on the ethical and the legal aspects with the health professionals, with patients, but also with citizens. And we decided to organize that in networks. And when we started in 2017, we thought the pilot would be launched in 2018, but it lasted till mid-2019. So you have to take enough time to do that. Now, where do we want to go to? And it's there that the PCP comes in. So the next slide, you can see that one element in this whole introduction of NGS is the NGS profiling. And it's there that actually an important cost for the labs, especially if you want to give it to all people with, we focus on people with advanced cancer, so metastatic cancers, which in Belgium, from the data that we collect now, is about between 10 and 15,000 people. So it's a considerable cost. But the important thing is that you come with a system that allows you to integrate testing, analysis, and reporting in a way that you can afterwards reuse this data for clinicians to, let's say, when they have a new patient, that you can guide them in from past experience to look at what treatments are best fitting with them. And then this information is also used in cases where standard of care is not useful anymore or not applicable, to bring people to clinical trials, find matching trials, and give the opportunity to these patients to have an additional, let's say, or an opportunity to still get access to some treatments. And it's there that the PCP figures in. And it's important in that sense. And what I really like about the PCP initiative is that there is this obligation that you work with several countries. Because if you want to generate evidence, and I heard it in previous slides, this is an important element, generating evidence. First of all, for evidence, you need data. These data need to be somewhere standardized, harmonized, based on good quality, and it should be shareable. And it should be shareable in an interoperable way. So it means that you have to come to a common agreement how you're going to do all this analysis, how you're going to store this, analyze this, and share it. Because in many cases, and especially if you go to personalized medicine, you start to have few cases for a particular indication that you find. So this was a main driver. So the PCP, the OncoNGS PCP, is a collaboration between Belgium, Italy, Spain, Germany, and France. So we have a nice coverage. Now, I think COVID was a main trouble for us, because you can imagine we have a lot of groups that are very much driven by research. So researchers like to discuss, and we could hardly sit together, because we had the kickoff just before the COVID crisis. And afterwards, we had to do everything by teleconferencing. But we managed, thanks to Rosanna and Maria also, to streamline that a little bit through 120 meetings, teleconferences that we had over 19 months. We're very glad now that we can come back together, and we had already 3 meetings face-to-face. But that is definitely a challenge with this, in the COVID crisis. And the other challenge was, when we started, you have to think way in the future, because your unmet need is there, but it has to also be challenging enough to demand for research and development in 5 years, because your process is about 5 years. So that means that what you ask has to be well thought through, that it's still relevant at the moment the PCP is ending. Now with OncoNGS, I think we managed that. And it's actually we are focusing, I'm not going to comment on the topic, but we're focusing on the hot topic that is now really being addressed in many different projects, liquid biopsies. And in fact, it's due to the fact that the buyers were really research directed people. They knew where they had to come to. They were clinicians, so that was very good. Now, another important element in the PCP that we really appreciate is the fact that there is the opportunity to put price as a criterion. And that is for the payers essential. I had yesterday a discussion with the payers and all the NGS labs in Belgium, and the cost is a topic, because we have to budget the cost at a certain moment. So it's very important that whatever you ask to be developed in the PCP matches a fork of of price that is acceptable for the different countries, payer systems. And I know that in Italy and Spain and in Germany, these are regional ones. So that's even more complex than, for example, in Belgium and in France, where it's a national payer institute. But that's a very important element that we really appreciate in the PCP structure. It's also challenging, of course, for the market. I know that we in OncoNGS, we demand a lot, but it's what actually yesterday it came back. Price is one thing, and local deployment analysis is close to the patient is an essential element also for having this technology being successful. IVD is another element that we will have to discuss at a certain point, but I sense that from the buyer side, some flexibility in the IVDs will be necessary, because otherwise probably it will be too restrictive. So I think what we didn't foresee at the moment that we launched is the European health data space and all these opportunities that are there. But in fact, the reason that we have standardization and harmonization as an element, I think the outcomes of such a project would be very, very well linkable to the principles that are now being built around the European health data space. Because we, as Cienzano, we are very heavily involved in all the aspects of the European health data space. So I think another element that is to be considered in this case is reporting. Reporting is extremely time-consuming. So you have to make sure that reporting is integrated in your solution. So I think I will leave it there. And we can have a discussion afterwards.
Thank you very much, Mark. So now I move the word to Yves Verboven. Thank you to the previous panelists. So Yves, the stage is yours.
Thank you very much, Rosanna, and also a big thanks for the invitation. So perhaps a quick introduction from my side. While I'm currently leading the EU for Health Solutions, the previous role and still a role is in advising MedTech Europe, so as a trade association. And within that setting, we're also having been engaged into the area of the innovation procurement in the RIFI project. We have been lead coordinator on this, given the very keen interest from the MedTech industry in this initiative. And I think the rationale or the reason why this is such of interest, this initiative taking place at the European level, but also taking place at national levels, is somewhat what was expressed before, where it's quite clear that the health systems are actually expressing the needs, which is further articulated into the calls. And so these innovation procurements are really major opportunities to shift from a pure supply side and thinking what could be technological innovations being developed, towards moving into a much more a role of responding to specific demands, and in that way to see what type of technological developments can be conducted in order to be then responsive to specific needs, and in that way become much more a partner into the ecosystem. Within that context, we're also advocating to really move towards a value-driven approach. So ultimately, what is being valued by the health system, to have a clear understanding of this in alignment with the values that the system is having, and then coming also into a mechanism where ultimately this value will be rewarded for the value that's being created. So overall, in this dynamic from the MedTech industry side, it's clearly a quite important initiative, and it's a key initiative, and it's actually one of the few initiatives that exist to really bring this bridging between the demand side and the supply side, and to move this then forward. And so within this aspect, what is certainly of major value also be seen in the PCP side is this ability for the European SMEs to actually be part of this dynamic. So in that way, to have also a mechanism outside of all the initiatives which are taking place at national levels to promote innovation, to promote technological development, to have actually this instrument, which is much more on how to actually respond to a specific need, and to already make the bridging from the start to make sure that what you're actually developing is actually responding to the specific requests that people are having. I think one particular aspect that is critical to be taken into consideration is the specificity of the different health systems in the different countries. So I think there, what is important, and what also came forward very well in the presentations, is the ability to have this, let's say, more collaborative approach to be responsive to the specific needs that health systems are having. So there might be some specificities in the health systems which need to be addressed, again, which can be addressed also by specific developments that are taking place. And I think that will be an important aspect to be taken forward. And the other aspect that I think will be important from an industry perspective is to make sure that there is a further alignment or cooperation taking place between national initiatives in this field and then European initiatives in this field. And there was within the Health Union the topic of looking how potentially legal frameworks can be put in place to allow co-financing. So really to ensure that there is this collaborative approach of what's nationally identified, what's European identified, and really having this moving forward to further accelerate ultimately the introduction into the health systems. And this, I think, is a final point from an industry perspective, is to see which is ultimately the pathway. Which is the pathway from moving from the research development responsive to the needs into then the introduction into the system. And while I'll agree it's important to have a research phase and then an introduction phase, I think it's also critical to start thinking much more in the area of the innovation partnerships. So really moving into how to make this connection, how to in the projects ensure to advance really from individual projects to what I would call more programs, so that you really have this continuation and a flexibility in this continuation, and also an accelerated dynamic, because currently it takes a long time to get everything prepared, get consortium set up, and then you have at the end of the PCP, you have to be again seeking for another initiative. So I think this dynamic and much more a program approach will be quite important to facilitate the introduction of this innovation into the systems, moving from the research side into the accessibility of this innovation, which we would see as an interim phase before really taking it up into the full health system. So I think it's important to also from the clinical side have this preclinical conduct already in the research phase, but then move into a clinical conjointly partnership development, potentially under a PPI, in order to have the further development, to have the full value propositions to then be taken up into the reimbursement systems. So I think it's really unique and great initiatives that's driven by Europe, responding to really key questions. When I see also the initiatives under the public-private partnership on the IHI, where we're also looking at early feasibility studies to be brought in, all of these components I think can be connected in order to really get then for Europe an excellent pathway of bringing innovation, innovative solutions in response to the specific needs. And again, for ensuring that within Europe we're taking a lead of doing so. So I'll leave it at this, and I'm happy to further have, of course, the dialogue and the discussion.
Thank you very much, Yves. Unfortunately, now the time left is we are already going beyond the time, and we should also give the word to Ramon. But before going to give the word to Ramon, I would like to make at least one question to each of you. And we would like to start with Carmen, because with Carmen, we introduced already a lot of elements that I believe are very relevant in the discussion, and one element also was already introduced also by Sarah. So I also wanted to also that she was already mentioning like a fast track, regulation for the medical device, for the for this innovation coming through these PCP initiatives. And Carmen, we were mentioning something like this during our call. So maybe and also you, Yves, and you, Mark, we're elaborating also on the concept of local initiative, international initiative. Not always needs to be international initiative, but still this standardization, harmonization of data and some reporting, yes, because it's a cross learning. So, Carmen, what do you, what are you thinking about these points?
Yeah, well, thanks, Rosanna. So what I can say is that the difficulties concerning the access to market or for innovation to reach to the market are not unique for the innovation procurement instrument. I mean, the path to innovation in healthcare, the access to market is quite long. So, I mean, these kind of discussions we have it also in the context of our regular support to consortia in research and innovation projects. So, I think that the important part is that all these things, I mean, the regulatory requirements, the validation requirements are known in advance, right? This is not something that you discover at the end of phase 3 or when you are, or even at the end of phase 2. So the important is to anticipate these requirements, to anticipate already from the moment you are considering a proposal, you are preparing it, you are looking, you are very, I mean, we put a lot of focus in having a very good preparatory phase, considering the market consultation and the different requirements, but maybe we should put more focus also on the requirements at the end, those that will impose or that will facilitate the access to the market. I think that the point raised by Mark was important indeed. The evidence needed, the fact that you have big consortium across Europe should be considered as an advantage in that respect, because it's much easier to have the evidence in that configurations that in maybe more local ways to use this instrument. So this is an advantage that needs to be built up on. But I think the important part is to anticipate that and to see maybe you need to have more longer, and maybe we are too strict in the questioning of time as well, because at the end of the day, if you don't have, if the final phases are not done, the product, I mean, the procurer will never be able to acquire, and there will be not upscale of the innovation. So our objectives will not be reached. So my advice would be to maybe to engage more with regulators as well, because I think that this is the same advice that we give in general. We are in very close contact with the European Medicines Agency and more than in the past, because we want to achieve more impact in general with Horizon Europe. So this goes through consider all the different phases that you need before you get to the market. So what Yves was mentioning about early feasibility studies, many different, I mean, there are different ways to look at these aspects, but for consortium in particular, my advice would be to consider all this since the beginning, engage with regulators, because indeed, maybe there is a certain way of doing things already from the beginning. I know it's difficult to ethical approvals is something very difficult, but all that is known from the beginning. So I think maybe, and as I said, engage with this coordination and support action that will start. I cannot yet mention more things because the grant is not yet signed, but they will be looking also at these aspects, which indeed are barriers. But what is the alternative? I mean, that's also another point. I mean, if these there are not many alternatives, so let's try to improve the ones we have. And I think engaging with HTAs, with regulators, looking at the cost concerns. I think this is an important point, and NGS has done a great work on that, because indeed, if these considerations is not going to facilitate the project by adding all these considerations, but maybe it's going to facilitate the afterward of the project, because I mean, if you don't consider that, at the end of the day, are you going to be able to acquire, to further procure, to reimburse, so I mean, there are different elements that need to be considered from the beginning, even if those things are not going to facilitate a process which is already particularly complicated. But I think that I would like to end with a positive note, because I think that at the end of the day, it's the best. I mean, it's a quite good way to ensure that you as procurers will have what you need. And otherwise, the only solution is to wait to see how the supply side will come along with a product that potentially will address something, but not all. So I think that let's do our best to improve the use of this, what innovation procurement offers us. Looking at different possibilities, innovation partnership, yes, of course, there are different ways, but we have to continue using them, testing them, and improving them.
Thank you very much, Carmen, for replying to somehow all the inputs that we have received. I'm sorry, even Mark, but really we are running out of time, so I don't know. Really. I think that we should close it. We should give the last word to Ramon. You had at least the opportunity, not already during this expressing somehow your keynote speak, no, your ideas, and but Carmen really, I think, that closed it very well from European policymaker perspective. So let's leave it here in this way. And Ramon, hopefully you can now close the event.
Okay, Rosanna, can you hear me?
Yes, very well. Thank you.
Okay, thank you. First of all, thank you. I would like to thank all the attendants for joining the event, and I would also like to congratulate and to thank all the speakers for their contributions. And I'm sure that if we have 2 or 3 hours more, the discussion will go on. But unfortunately, time is consuming. Just 2 minutes for share with you some final conclusions, not only related with the events, but also related with anti-superbugs. First of all, I'd like to point out that anti-superbugs has not been an easy project. PCPs are not easy projects. PCPs focus on detection of the presence of resistant microorganisms are not easy projects. PCPs based on detection of the presence of microorganisms within the framework of an epidemic has not been easy projects. So I'm sure that you agree that nobody said that it was easy, but I'm also sure that if everything had been easier, nothing would have happened either. So even all this situation, even so, the project has gone ahead. I'm sure that the commitment of all the partners, the professionalism of all the partners, and the expertise are clearly key elements of successful of anti-superbugs. And for sure, also the support that we have been received during all the project from the Commission through the different project officers, as well as from the evaluators. And with all of this, my thanks and personal appreciation to all of them, to anti-superbugs consortium teams, Aquas team, also the Commission project officer, as well as the evaluators. I'm sure that the needs of healthcare provider hospitals to increase all related with controls related with infections in the next years. It was a priority before the epidemic and will remain a critical situation for next years. Thanks to ANTI-SUPERBUGS, we already have two solutions. So the new challenge for procurers, for payers, also for policymakers and for the Commission itself will be to ensure that these solutions will be deployed and they will become part of the day-to-day life of hospitals, and that they have clear objectives, reimbursement schemes, as Yves said. I'm surely that rather will be one step beyond, one step further, but I'm also sure that we need more projects like rather, more procurers and more cross-border projects in the next years. As in a game, the coin is already tossed, so we must decide if we want it to be heads or tails. So it's our decision. Thanks again for the effort of the consortium. Thanks again for all the support from the Commission, and thanks to all the attendants, and good luck to everybody.
Thank you, Ramon, and really thank you to all the entities that made this project big. I wanted to say it by my own, because really without Vincatic, or without Provincia Autonoma di Trento, without Helios, without Mutuo di Terrassa, Sheffield, UCA, RISE, Sara, without you, we could not really have this project in place. Without the European Commission, really, thank you also, Elena, to stay here up to now, and Carmen, and without you, and also thank you to the industry that supported us along this process. To me, I just want to say it because I was writing the proposal, so I was fighting during all this journey. So I'm happy that we are all here, and thanks to everybody, really. So to me, it's a moment of celebrating. I don't know if you all want to add, and Maria want to add anything, but thank you very much to everyone.
Nothing really. Again, thanks to all of you for this great effort. It's been a great journey. So yeah, it's time to celebrate. Thank you, everyone, and wish you a great day.